student orgs? Anything cool happening this way? Anybody participate in Relay for Life last Friday?
Hell no.
Pretty cool, pretty cool. Heard it was a good event. Good job, guys. Thanks for showing up. Yeah? So there's a canned food drive. Where can they donate? Where can you donate? Okay, so in student affairs, you can donate canned goods. Yeah, canned goods, East Texas Food Bank, support people. Actually, has anybody heard of what a food desert is? Oh, I have a head nod in the back.
I've
What's
heard
a
of
food
dessert.
desert? Right, so it's a community that doesn't have access to specifically fresh fruits and vegetables. Smith County is a food desert, and the surrounding East Texas area is filled with food deserts as well. So you're really making a big impact when you can donate things like canned vegetables to that and that kind of thing. It's not fresh, but at least it gives them that little bit there. Snappa is selling jackets, is that right? Yes. So Snappa is selling, so you can get yourself a Snappa jacket. That's pretty cool too. They're pretty snazzy if I remember from last year. So. Oh, they're new and improved, so you can get this year's edition.
Oh.
Yeah?
SGA is having midnight breakfast tonight at the Met from 10 to 12. Free breakfast for anybody that wants it.
Oh, nice. SGA is having midnight breakfast tonight from 10 to 12. So that's pretty good stuff right there. Is there a t-shirt? Is there a t-shirt?
No.
Oh, wow.
No.
That's okay. Anyways, so for today, your team will need a piece of butcher paper. We'll be doing 3 cases today, so make sure that as we go through our cases to document that you were here today by initialing beside your answer so that I know you were here, and you sign legibly at the end. There's a lot of creative ways to document last time, but I need it done that way so that later on, when you get credit for your grade, I can say, look what they did, they earned this, go them. That's what I have to be able to do, so it's important that you document what you've done today. So make sure you do that. Otherwise, get yourself a piece of butcher paper. I'll put the first case up.
So yeah, our videos are due Friday at 2. Thursday I have rotation.
And Wednesday we have lab.
It looks like we're going to have to do it after class sometime. That's fun. Yeah, fun.
I read it. I'm trying to find it. Oh, here it is.
Ellis squared, question mark?
I didn't go back to the
I guarantee you she's going to give us Darth Vader. She's going to have COPD.
Oh, no. I think so? Okay.
We get the markers out of the box, Kevin. Please. Pretty please.
Where's the box at? I don't have the box.
You don't have the box?
There's no box.
Oh, did they put them up during the exam? Oh, you got
Put it in the pack.
What?
I went over her place to study. I don't know what you put in the packet. I didn't even know the packet.
I'm
Yeah.
trying to make a PowerPoint.
She put like every possible combination, you know, every possible scenario.
But the one that's still, I'm still is that old lady.
The one that didn't want to take their medicine?
No, the old lady who they threw on the high and took this hat for no reason. Well,
think
she
it was
had
a mistake.
yeah, her LDL was 22.
That was really low. Yeah, I didn't know what to do.
Increase the medication.
Yeah. I just said, keep doing what you're doing, whatever.
I didn't.
Because we didn't know.
Because remember, she was like, it's no real low, but everything says 40. Well, she was in below 40.
It's supposed to be beneficial for older people.
And then you're better.
So our first patient today,
Taking the proper medication.
our first patient today is LS's sister, LS squared.
Oh my god.
She's 75-year-old female presenting today. She heard good things from her brother, so she's following up with you all. You have her past medical history there. She's only taking one medication right now. She's married with grandchildren and has a twin brother. And we have her labs are here. You've got her CMP modified in the upper corner and her vitals in the lower right. And then what you're going to write on your butcher paper for the first three is going to be what risk factors should be contributing specifically to her blood pressure today. You need to name at least 3 of those. What stage hypertension is her blood pressure? Make sure you not only stage her, but you support her answer as to why you chose that. And then, do you think she has primary or secondary hypertension, and support your answer as to why? Okay, so I'll go ahead and put the case back up. One thing that I did want to do before we get started today is recap what we covered last time. So last time we talked about her brother. Her brother was LS. And what was the root cause of his hypertension? CKD. So he had CKD and he was older, right? So those 2 things were contributing. And because of that, what were the agents we could have started in him? An ACE or an ARB. Good job, good job. If it had been primary hypertension, what would have been our 4 categories we could have used? Name one. So we could use an ACE or an ARB, and there's 2 others. A thiazide or a calcium channel blocker. If we were going to start 2 agents in somebody with primary hypertension, what would be one of the primary agents? We would either start a blank or a blank first. ACE or an ARB first. And then how do you think we would decide whether to add a calcium channel blocker or a thiazide after that? What are side effects of those medications? What? So you could have a cough with an ACE, but what if you started an ACE or an ARB and they're doing okay with those? What would make you decide whether or not to add a thiazide or a calcium channel blocker? Sorry? If they're not a goal, right? We'd want to go ahead and add one. I heard an electrolyte over here. Potassium, good job. Yep, so if the potassium is high or low, would we be concerned? And what drug? So if they had hyperkalemia, what would we be concerned about? What drug would we think that would be? ACE or the ARB would be contributing to that, right? What if they had, say they're already on an ACE or an ARB, but their potassium is still hanging out at the bottom of the range? Which one would we want to avoid? The thiazide or the calcium channel blocker? Thiazide, right? What is a side effect they might not be having from the ACE or the ARB? Maybe they just naturally have this that would make us want to avoid a calcium channel blocker. What do the non-dihydropyridines, nope, that was wrong. What do the dihydropyridines tend to cause?
Dry cough.
Edema, heard it over there, good job. So if they have edema already and you want to add another medication, then you wouldn't want to start a dihydropyridine, right? Because that's going to cause peripheral edema. They're already having that, and that's going to make it worse. Just like if they had potassium that was near the bottom of the range or even a little bit lower than that, you wouldn't want to add a thiazide, right? Because that's just going to drop them lower. So think about that as we get into these more complicated cases. What comorbidities do they have? What side effects do they have? And what might you want to add in light of these things? We're not there yet today, but I wanted to go ahead and toss it out there.
I usually hear when you check on the racial thing, it'll say white,
Oh,
comma,
great point.
non-Hispanic.
There's a non-Hispanic.
I asked if on the little treatment thing, it said you can start an ACE or R, and you can start like the thiazide or calcium channel blocker. Do you start
I
one,
guess
and
if you're
then
mixed
it's
or
not
not?
working, you start the other, or can you start two?
Saying you're not a mixed race?
How many teams think that we can start 2 agents at once?
Not really.
How many teams that we should only start 1 at a time? Okay, let's try this again. It's okay to have an opinion, I promise. How many teams think that we should only start 1 agent at a time? Or people, you don't have to agree with your team, it's
That was
okay
a
right
nice
now.
little noise.
How many people think we can start 2 at a time? So the correct answer is we can start 2 at a time, but you have to start 2 at a time carefully. So, and their blood pressure needs to indicate that you should start 2 at a time. So if they're over 20 over their goal, then you can start 2 agents at a time. But you'd want to start 2 agents that don't interact with each other. So for example, you're never going to put an ACE and an ARB together, right? So both of those we would want as the base of our regimen, but we would never use them in combination because it can cause what? You got this. Which one? So it could cause hypotension, right? Right? An ACE and an ARB, what do they both put the patient at risk for? What organ can they affect? Kidneys, right? And so you wouldn't want to start an ACE and an ARB in the same patient because it can cause acute renal injury, and that's not going to end well. So you choose one or the other to start your regimen out, and then you add on a calcium channel blocker or a thiazide. I should throw in the caveat here that you will go to some practices that say that thiazides are the be-all and end-all, and they will start with thiazides consistently. But the data right now is in favor of ACEs and ARBs as the base. So I don't want you to go to a clinic somewhere and be like, but we said that the ACEs and the ARBs come first, and this person was started on a thiazide. There is a case that can be made for thiazides first line as well. However, in a society that suffers from lots of cardiac remodeling, you haven't gotten to this yet, but ACEs and ARBs protect against that. And so keeping that in mind, that's one of the main reasons we start there as well. Okay, so enough of the recap. I just wanted to make sure, because you know you've slept a lot since the last time we talked, that we recapped about
Yeah,
what
right.
happened. So, or maybe you haven't slept enough because you had an exam yesterday. I don't know. But either way, I'll go ahead and put the case back up. Make sure as you're putting your butcher paper answers down, again, that you mark your initials beside what you contribute and you sign at the end. And make sure that you answer the questions. So if I say to name 3 items, make sure you name 3 items, that kind of thing. So just make sure that you're answering the questions that are up here specifically for full credit. Okay?
So age,
75, right?
yeah, she's 75, so that's over the age of 65 and running. She's on
Some labs.
CAD. Is that the chronic artery? Or what is it? CAD, what is that? Chronic, something artery disorder, right? Or disease? Oh, I wrote it down somewhere.
Oh man.
Coronary, thank you. Yeah.
Coronary artery disease, yeah.
So I would say that's a contributing factor. Right?
Yeah. I mean, that's pretty much ASCVD, right?
Pretty much, yep.
But I don't know if that contributes to hypertension.
Lay your head down.
Lay your head down.
What? You trying to get a picture?
Thank you.
I'm gonna creep up in the. My eyeball's gonna be in there.
No, because my picture's moved. Yeah. Ischemic transient. Okay. It's a T. Transient is first.
Oh, transient and ischemic attack. So
That's a stroke.
basically stroke, right? Okay. But that they both fall under that ASCVD, right?
And that's for dyslipidemia. Is that also for hypertension?
Well, the artery disease, I feel like that would definitely be contributing to the hypertension.
Oh, here's the risk factors.
Um,
Age, diabetes, dyslipidemia, albuminuria, premature cardiovascular disease or history of it.
brain, she's had the stroke, the transient ischemic attack is one. So the CAD, TIA, and her age are the three factors
And the patient
contributing.
is 70. How old is she?
75.
75.
Patient is 75. Okay. So we have that.
I'm gonna try to put all this in a PowerPoint
We
if I
have
can.
Questions?
I'm getting pictures over a screen.
Okay, so we got the three. She's in stage 2, right?
we don't have one.
Hold on.
Oh, CAD and TIA. So TIA is under here, and the CAD, well, it says angina, heart failure. It's not exactly listed, but I would assume coronary
It's part
artery
of the-
disease
yeah.
is probably a risk factor.
That's peripheral artery disease. I think coronary artery disease is a type of that.
That might,
Well, actually, no.
It might be heart failure, isn't it? Isn't it heart?
One way or the other, it's going to fall in here.
Yeah.
It's like in between both those.
Exactly, yeah. So I would say that that's one. I mean, you could put PTSD on there, but I mean, as for like, but that's more of the transient factor that they.
Does she have
talk about.
PTSD also?
Oh
Yeah.
yes, TIA and CAD.
They've both been through it all.
Yeah.
Yes,
That's
yes.
what you said.
That's the second phase. Yeah, I agree. She's stage 2, even though her diastolic falls in
And the 82, yeah.
pre-hypertension. But you
Yeah,
got to go with the highest.
agreed. I would say it would be secondary, wouldn't you? Because it's caused probably by the coronary artery disease and the stroke.
Don't do everything. We gotta pass this around.
Yeah. That's right. We all need some points too over here, girl.
Let's give.
Go ahead and do a question. How old is she?
75.
75.
She's over the age of
So we got
65.
75-year-old kidney, right? But I don't have her.
Well, her.
It,
85. That's pretty good.
What?
Her
The
crea-
CLCL?
her
is it a,
crea-
you don't know the older that you get.
Does she smoke?
We can get a phone.
Doesn't say.
So,
I'll pull up that other picture and see.
I would say secondary just because it's probably not genetic.
She refuses to take her meds.
Yeah.
Wow.
yes. So, but we don't have her weight to even make that judgment.
So do we agree secondary?
What question is this?
3?
We don't have two answers.
Yeah, it's stage 2. Because her average for the last 3 visits was 162.6. And her diastolic is only 82, but you go with the highest one, which classifies her as stage 2. And make sure you explain why.
Did she say water?
Yeah.
Yeah, well, she wants explanation
Yeah, it
first.
says why and support your answer.
Oh, okay.
So it would say her average systolic blood pressure over the last 3 visits is equal to 162.
Okay. I'll just write it and then I'll go back and research it. 162?
Yeah. I mean, I got
She has
162.
dyslipidemia. Dyslipidemia.
Over 82.
Well, if you're just doing systolic, it was the 162.
Yeah.
Yes.
Okay.
What's her LDO?
But the other one was,
We don't know.
No,
what you call it, right? But we have to go with the highest one.
Yeah, highest,
Yes.
highest stage.
I'm looking for it. I'm looking for sticky note on top of it.
Page 4.
And sticky note. Thank you.
Alright, and then
Leave it there. Don't worry about, we don't have to worry about the other one.
it don't matter.
Does she have CKD? We don't know the albumin.
No.
Okay. Go Norway.
So did we already diagnose her with stage 2, you said?
What?
We already diagnosed her with stage 2.
Stage 2 hypertension, yeah. And then on this last one, is it primary or secondary? We're thinking secondary. Primary is based off of genetics. Secondary is based off of other things.
Oh, no.
She's, yeah.
Okay. I agree.
You like it, Alex? I'm writing small. You and Bryce.
Yay.
Yeah, we got 3 cases today.
Yeah, I gotta keep it small. What's our argument for secondary?
Primary, we have no reason to think it's genetic. That's not in the case. Let's see.
Her sodium is not out. It's not a. How do you say it? It's within normal range.
Okay, so sodium
Sodium.
levels. And there is nothing to support. Well, I mean, inpatient does have other factors that.
You say secondary?
Yeah,
Due to what?
that's what I'm asking.
Why is it not primary?
We said it wasn't primary. It's primary is due to genetics, more so to genetics. They don't have an actual cause for it. But secondary hypertension is hypertension that's caused by another disease state. And because she has coronary artery disease and she's also had the TIA,
Mini-stroke.
I think that's what's contributing to her hypertension, not genetics.
Yeah.
Does that make sense? I know it says common diseases and it's not necessarily listed, but I think the hypertension is due to something else.
She has osteoporosis and she's not taking no meds for it. That can raise. I think that can raise your blood pressure. If you're in pain and you don't refuse to take medicine.
I mean, how are we gonna know if it's genetic or not? You know?
Well, that's the thing, you can't.
She has PTSD and she's not taking her medicine. That can raise blood pressure.
Didn't her brother have high blood pressure?
But do
And we don't know.
Maybe it is family
So I
thing.
think there's.
Maybe, but they both had PTSD
True.
you feel
Wait, how do you know her brother had high blood pressure?
because
It
it was
was
the one that
last
we did last week.
week. Yeah.
On
Luke,
Friday.
it was Luke Skywalker.
The
What
illness.
the heck? about to say, dude, if you use deductive reasoning and you got that shit,
You're like, how the hell?
this guy,
Which she does. Coronary
freaking
artery.
genius.
Predicting the future.
Coronary artery disease cause hypertension.
Well, it has to here. You can
Give you just a couple more minutes to polish up those answers.
So what's your argument for secondary? Well,
I would say because she has coronary artery disease, we think, yeah,
that's good.
She's taking the
Mm-hmm.
Is that a side effect?
the side effect, no, that's
That's
the
the-
high cholesterol.
I know, is it a side effect? Is hypertension a side effect? Yeah, if you say
Okay, so untreated high blood pressure is the arteriosclerosis or whatever, or plaque buildup in the arteries. When those blockages occur in the arteries that supply blood to the heart, the end result is coronary artery disease. So because she has high cholesterol, it is contributing to her high blood pressure, and that's what's causing her coronary artery disease. So sodium levels are normal, and we feel that her CAD is what is causing the hypertension. Is that what we want to say for our argument?
That,
Yeah, I see CD, yeah.
Okay, so sodium levels are normal. We feel patient's
I mean, how are you even going to know it's primary though?
No, there's not a
There's not a
cause
test.
90% of the time.
I know. That's so stupid. It says that's 90% of adult cases too.
What teams are still working? Got one right here, one back. Okay.
So there's a 90% chance this is primary, but there's a 10% chance it's secondary.
I mean, the way I did it in my head was that primary has no reason for calling it, for causing it, excuse me, but secondary is due to something else happening.
It's due to specific ones. CKD, Cushing's, corticosteroids, sleep apnea, thyroid disease, and
Do you think that's all of them?
aldosteronism.
You think that's all the diseases? that-
No, see, it says
I don't think so.
common causes of secondary hypertension,
Yeah. For
which is why
me, that's a flag there that makes me go, well, what's the other ones?
I would say that her high cholesterol is what's causing the hypertension.
Sure. I mean,
Because it
I'm on
says
the
a
same page
cause
with y'all.
can be identified in secondary. If we could get the patients, well, what were her levels? Is it controlled with the,
See, how do you know if it's chronic hypertension?
let's see, we don't have her LDLs.
I got that. Chronic.
Okay, let's talk about these. For this team here, one thing I did want to ask, just kind of to put together the big picture, what do you think about her statin therapy? Is it appropriate?
Yeah.
What was it at?
Oh, wait, no. It needs to be.
You got this.
Rosuvastatin 20. It's on a high intensity.
It's a high intensity, which she needs to be on.
She's
Because
75,
already got
and we
the
don't.
CAD.
We don't have the HDLs.
Huh?
We don't have the HDL levels.
Well, that doesn't matter. She has the ASCVD or whatever, and she's less, or she's equal to or less than the age of 75.
True.
So
That's
that
high.
would
She should be on
automatically
moderate.
be high. Huh?
It's moderate.
If
CAD,
if she's over 75, right?
there's 75 or
If it's less than 75, you do high intensity
greater
because
than or equal to 75? Or is it less than or equal to
She's got
75?
high blood pressure, and she has something else.
Now
Her
I'm
age.
second guessing myself.
Yeah, so
ACVD, the
She
two
should be
risk
on a moderate.
factors is
moral
high.
of the story, don't miss the forest for the trees, okay?
No, she should be
Good.
because she's 75.
Yeah.
So
equal
her
to high
racemostat
intensity.
is at 20 milligrams,
And
which
her
would
goals
would
should
be
be
what
like 70
intensity?
on
High
LDL.
intensity, right? But what is her age?
75.
Right, so we'd like to do a chart review, maybe see how did we get to this number, was she started on this, what was her baseline LDL, how did we get here? Because she should have been started on what? Moderate, which would be your super what?
I agree. I agree. Based on what you said, makes sense.
Got a question?
Oh, I'm just curious why it's moderate when ASC by CVD for the TIA and the CAD is less than or equal to 75 years of old is a high intensity. So she is 75. We would do a high intensity. So she's not less than. She's equal to.
Great. So we have a good point over here. She says less than or equal to 75. And in this case, it depends on her birthday, right? Because up to 75, is she older than 75? I don't know now, right? But, and we're honestly splitting hairs about
Yeah, that's
yeah,
good too.
but it's true. Good thought, good thought. So while I'm over here, give me a risk factor that LS has for her hypertension.
Age is 75.
Okay, why is that a risk factor?
She's over 60.
She's over 65.
Right. Okay, so she's over 65 years old. What about you guys? What was
Sorry,
another
you're
risk
writing.
factor you put down?
Dyslipidemia is another one.
She has dyslipidemia. Okay. So dyslipidemia literally translates to mixed lipids. We don't have a lipid panel, so what else would you be trying to say with that statement?
Go get lipid panel.
So she's on cholesterol medication.
Statin
What?
use.
What else in her past medical history?
CAD.
Right, here we go. Yeah. So what is it?
That's medical history of TIA and CAD.
Which would be evidence of what? Right? Yeah. So she has evidence of atherosclerosis, goes back to pathophysiology, right? Narrower openings, higher blood pressure. There you go. What other risk factors does she have, this team here?
I don't think it's right, but the family history of premature CVD.
Okay. So we don't know if like an ancestor had like ancestors, that sounds kind of weird. We don't know if in her past medical history we had any early CVD, but what we do know is her brother, her twin brother, also has hypertension. So that would be significant. So good thought there as far as who else in the family might have it. If her brother is the same age and he's a twin and he's got this, then there's a good chance that she does too. What other risk factors are up there? This team here. Said she had stage 2 CKD. Yep. What's the upper limit for stage 2 CKD? 89. So she's at the top of the range, but she's still kind of going down that path. Does this surprise you, this team here for a 75-year-old?
No, because it decreases with age.
You got this.
Renal function decreases as age goes up.
I mean, she's got a good amount going on if she's had TIAs and CAD and osteoporosis and all this stuff going on. She's got some pretty good medical history going on here. Actually, her renal function's doing pretty good for 75 to be 100% honest. So she's doing pretty good, but she does have a little bit of CKD in there. Okay. Were there any other risk factors that were identified today?
PTSD.
Okay. So what did you decide to stage her as, this team here, and why?
Because PTSD was one for Luke.
Stage 2 hypertension.
From what she said.
Yeah, so we looked at the 162 and it was greater than 160.
And What if, like, the previous 2 times before this, it'd been like 130s? Then what would you have done?
Never.
Would she still be stage 2 hypertension?
That'd be pre-hypertension.
Right. So do we base a staging of diagnosis off of 1 blood pressure? No? I got a lot of no's. So team back here, why wouldn't you only base it off of 1, and what's the rule for that? So what is the rule for diagnosing if you assessing? We'll go assessing because we don't use the D word around here, diagnosing. So what would be confirmatory, I guess, of the patient having hypertension? How many blood pressures do you need? What does it need to look like to confirm the patient has hypertension?
We need at least 2 sets of blood pressure and at least 2 visits, consecutive visits.
There you go. Good job, applause. Right, and so we need to have that confirmed. So if she had been 135, 136, and then it jumps up all of a sudden to 164, first of all, we want to look for a contributing cause. But second of all, we need another confirmatory blood pressure. So that would be something we would need to do for that. Okay, so this team here, what do you think? Primary or secondary hypertension? Primary or secondary hypertension? Got this. Come up to bat, Paul. You got this. You got this.
I believe in you.
Stage 2.
Actually, we're not quite sure. We thought about primary because of our brother's condition, but based on stage 2 and all that stuff, so we're kind of confused. We didn't conclude. So we're going to guess secondary.
Okay, so I've got a kind of confused and a secondary. Okay, and the reason that you said that is because you pointed to her CKD, right? You said she's got a little bit of CKD going on, maybe that's contributing. Could be. But you also made another good point in that her brother has hypertension as well, so genetics might be playing into that. Most likely, this is more of a case of primary, but it is foggy, so you'll get credit for either answer, but the key is you need to be able to support whatever you put down. So just don't write down primary and then like she has CKD. Not going to get credit for that because that would be secondary, right? You've got to put something logical down for that. So keeping that in mind, it's a little bit fuzzier as to whether or not it's primary or secondary in her, but that would be something we would want to consider, is the fact that she has mild CKD, and granted in mild we're probably not going to see a huge jump in her hypertension, but it could be a contributing factor. Okay, so I want to make sure that we hit some key points before we move on. Okay, so she is stage 2. You need to remember what your stages are. Remember that primary hypertension has a root cause as opposed to secondary hypertension has something, I said that backwards, yes I did. Primary hypertension does not have a root cause, secondary does, and if we can address the root cause we want to. As opposed to in primary, it doesn't have a root cause, it's just like genetics or age or something along those lines. One other thing that could have been a risk factor for her that I'm not sure if we mentioned was her PTSD. Remember that her brother was taking medication for it. He was anxious just because he was kind of at the visit and wanted to get going and that kind of thing. She has untreated PTSD, and untreated PTSD would definitely contribute to blood pressure. Okay, so I need your flip cards. And so In your groups, decide what is her blood pressure goal. I'll put the case back up so that you have it. A is less than 120 systolic, B is less than 130 over 80, C is less than 140 over 90, and D is less than 150 over 90. I'll go ahead and put the case back up. Don't raise your cards yet.
Oh man. She's not frail.
40 over 90 again?
I would say.
I mean, again, I don't
Yeah.
feel like she's frail.
I mean, she's CKD and elderly, so that kind of does
Princess Leia.
goes with
Like,
both.
Yeah. She's General of the Rebel Forces, so
I don't think she's frail.
yeah. It's pretty tough.
140.
So over 50. So would we do over 50 with an increased risk of CVD without diabetes, or would we do most patients, including diabetes, CKD, and elderly?
Well, she has a vascular disease already.
See, so that's why I thought increased risk of CVD.
Oh god. Oh.
And she has C80.
She's not getting down to 120. She's 80 years old, 75.
You know, that's a good point. Maybe she does need to be 120. That's crazy.
It says we can do it as tolerated without undue treatment burden, but no, she's not getting down.
Well, yeah, unless you could get her on her medications
She
to
already
control
not taking
everything.
something. She already
So again, A is less than 120, B is less than 130 over 80, C is less than 140 over 90, and D is less
So
than
do we want to
150
do
over 90.
140 over 90 just to be safe, or?
I guess it would help
I don't know.
you
It seems kind of realistic to expect her to get down to 120.
Especially at her age.
She's at 160.
can we bring her down?
Yeah.
She was that far. She was stage 2, so. She's at 160 right now. No, too low. She's already had it. She had it
I kind of feel the less than 120 is her goal, whether she gets there or not is irrelevant.
Short-term goal versus long-term goal?
But yeah, short term. But I mean, I don't know.
Okay. So on the count of 3, go ahead. You need to use your flip cards, by the way. Not dry erase words. Flip cards.
What do we want to do?
Okay.
C, A or C?
This is a mean class, you know, stealing each other's flip cards. I don't know about this.
Books? No books too?
Okay. So on the count of 3, go ahead and raise your flip cards.
Let's wait and see what everybody else.
1, 2, 3. Cards, cards, cards. Okay. So I see lots of C's. Ooh, we have good blend. Good blend. Okay. So I see C, D, and I see A. Okay. So if you picked C, I want you to send one representative up to go and stand over there. Come on. It's okay.
You called it, so you go here.
Yep.
You called it.
Your turn.
Yep, you called it.
And then we'll initially.
There should be a group of C people over there. Come on.
You called it.
You owe me one anyway.
Way to
Go, find your name.
I believe in you.
go. You got this.
If you pick D, then one representative up and stand right here. And if you picked A, over there.
I missed it.
Oh, you I know what y'all talking about.
What'd y'all see? What are you laughing at? I don't even understand the joke.
Be polite.
I told her, I was like, look at your shoes, look at your shoes.
Okay, so C, D, A. Wait, we need to get some separation between our C's and our D's here. Yeah, so there's a difference in between. Heather S and Heather S is the divide. Okay. Heather's or goodbye. You got it. Okay.
Dang, that-
So only one team can be right, right? There's got to be a right answer, isn't there? Okay. So C's, defend your answer.
So we said the her blood pressure is currently at 162, and she's old. She's 75 years old, and we believe when you get older, your arteries can take like a lot of pressure. So we want to reduce it to 140 over 90 as goal for now. Less than 140.
Okay. By that same logic, you could potentially say that you would have reduced it to 150 over 90 or for less than 120 over 90, right? Either way, we're still reducing her blood pressure. So why did you decide on 140 over 90 as opposed to the others?
Well, earlier we said she could have CKD, and I looked at the chart earlier, and that was part of the category for giving it to less than 140 over 90.
Okay. So you say she's got CKD, so
Yeah.
So, what other thoughts from this group of What do you guys think? What other thoughts do you have to support your answer? Because what's going to happen in just a second is I'm going to hand the mic to them, and they're going to try and tear apart what you just said and support their own point. So, what other things do you want to support your case
I
today?
love doing that.
She's not frail, so we can go ahead and get her down to 140 instead of 150. Less than 120 just seems kind of unrealistic given all her risk factors, and that's not really even a goal that we use anymore.
Other teams, I would go ahead to because there's rebutting all the points you're about to make. So,
She's not diabetic, so we'll have less than 30 over 80.
okay, so good job, these teams. Come on, good job, good job. Okay, what do you guys think for D?
Okay, so I'm going to first start with the CKD. It is a little bit low, but how we talked about earlier that her CKD is kind of good for her age. So that was my first thought.
What's your second thought?
Okay. Secondly, we did say that we don't think that she's necessarily frail, but she is older than 60, and she has also osteoporosis that is not being treated.
Okay, we originally kind of went back and forth with A, but then we decided that that's way too low for her age. And another factor, like Janine said, is she's 75, she has osteoporosis, so we don't want to bring her down too low because she has an increased risk for fall, and if she were to fall, her chances for breaking a bone are much higher due to osteoporosis. Okay?
Princess Leia doesn't fall.
We chose A because she's about 50 years old, and she had TIA before, and also she has CBD, so she's at increased risk of developing those ailments again. Dropping her blood pressure below 120, I think it's a goal. It's not gonna be like a precipitous drop, like you're gonna drop it, less than 120, and at least make the process happen. So we choose A. Also, she doesn't have diabetes.
Everything for me? Okay. Everybody, good job.
I refuse. What is the answer?
And those are exactly the kind of points that you want to make when you're going through a patient like this. So it goes back to what we were talking about earlier about a fit or or a frail elderly, and what the difference is between those two. When we look at this patient as opposed to LS that we had last week, she has other things going on, right? And you guys picked up on that. So she has TIA and CAD. So that's presence of atherosclerosis throughout her body, right? That's a sign of that. She also has osteoporosis. You picked up on that as well. So, and it's untreated. So a fall in her is much more serious than a fall in the patient we had last week, right? Because he has stronger bones than she does. And so when we look at this patient, she also refuses to take her PTSD medication, and she's not on any medications for hypertension at all right now. Maybe she self-discontinued those. So this is a different patient that we're looking at as far as this goes. A lot of good points made about less than 120. Keeping the Sprint trial in mind, if you took away the concept that she has osteoporosis and untreated PTSD, if you took those two things away, she'd be a good candidate for that, possibly. 75 is still a little bit older for that, but it would be the right category because she doesn't have diabetes, she has a CVD risk. It makes good sense. So we look at all of these things together, we'd probably end up going in her with, make it advance forward, maybe, increasing her goal to start with. Now we could buckle down in her, okay? We could, if she's tolerating this well, later on we could decrease that down to 140 over 90. If we had the chance to do that in her, we could do that. But we would want to start out slow because she's at high risk of adverse events. If we have a fall in her, a broken hip is going to be a big deal. You don't recover well from broken hips. And so that's going to be a little bit more of a frailer elderly picture. Is she super frail? No, she's walking around, she's getting around clinic, that kind of thing. But keeping the bigger picture in mind, it's she would be a good candidate for up here. Now, others of you made a good point that, well, she has a significant CAD history. She's got a lot of cardiovascular history going on there. It's true. And I know some physicians out there that would automatically jump to this goal in her. But this is a good place to start. If we're just going to start, 150 over 90 would be a good starting place for her. Okay, so keeping these things in mind, we want to develop a plan. Like her brother, she's already implementing lifestyle modifications, so the team would like your medication recommendations. So what medications do you recommend for her today? Be specific, make sure you do name, dose, route, and frequency, and support why you did what you did for those agent or agents, plural. And then what do you want to monitor for your plan? Base your plan off of a goal of less than 150 over 90. Okay, and I'll go ahead and put the case back up.
Okay, so for stage 2, it says you want 2 first-line agents started. So it says an ACE or an ARB plus a calcium channel blocker or thiazide. On page 6. However, she does have the CAD, and it says beta blocker, then ACE inhibitor, then calcium channel blocker, and then a thiazide.
And then for CKD, it says ACE.
Well, we could just do
And we will
combination.
reconvene at 3:15, just as a heads up.
So we could do a thiazide with an ACE inhibitor because under coronary artery disease, you're going to have an ACE inhibitor. And then at the end, you add a thiazide. And then also with CKD, you need to make sure she's on an ACE or an ARB. So, I mean, that would be the 2 starting agents.
So no beta blocker?
And see, that's where I don't know.
Yeah.
Just because, I mean, if you're, that's the common denominator between stage 2 hypertension, CAD, and CKD. Because her CKD is not for her age, I'm fine with not really worrying about that one.
Unless you want to do ACE inhibitor or ARB, then add a beta blocker.
Well, see, that's
Because
what
the
I don't
CKD.
know. Because,
Oh, she has CAD right there.
yes, I know that's what he's saying, beta blocker. But if you look at general approach under stage 2 hypertension, which is where she's at, you start 2 first-line agents.
Yeah.
And beta blocker is not under that. So that's what we were talking about. I mean,
Beta blocker, then add ACE or ARB.
do you want to just do CAD? Or do you want to treat it like stage 2 and do the 2 first-line agents? Because it says stage 2 is, indicated for over 160.
What in the
But
world?
that's over 160 over 100. She's 162 over 82.
Oh my gosh.
So it's all about what y'all want to do.
It's like, what do you think is worse, her hypertension, CAD, or her CKD? I think her CAD is the worst thing.
Yeah.
Not necessarily
So
because she's
CKD comes with the age.
yeah, and it's low. It's actually good for her age right now.
So
I
we'll go
would-
with the CAD then.
So I think CAD is
Yeah.
causing her hypertension to be so bad too. So maybe you can knock it both out with one go if you treat to the disease.
Yeah.
But I don't
I
know.
agree.
That's what I'm thinking, just logically, but I don't know what you would actually do.
So do a beta blocker and an ACE.
It says then, not and.
Well, the reason why I'm saying
This
do
is general,
and.
but she's beyond general because she has a compelling
When do you
indication,
add?
right? Well, no.
Oh,
Yeah,
that's
she
in
does
the-
have a.
She does have
at this point.
Yes.
So,
But she is stage 2, and so at stage 2 you need 2 first-line agents, and so
where does general take over? Where does compelling
well, I'm just
take
saying
over?
she's at the worst stage of hypertension, so you probably want to start her on 2 agents to make sure that you get it under control. That's why I'm thinking beta blocker and ACE inhibitor.
So wait, what was the goal? It was 150, right?
Which
So-
really isn't that much.
150. One therapeutic agent will bring it down 10.
Yeah.
So she would be at 152.
And we want her below. So with 2 agents, you would then have it below 150, which is her goal. So that's why I was thinking do both. So, did you hear that?
Is there a combination product with the beta blocker and the?
Well, I mean, okay, so here's my question. What is it going to hurt to put her on both a beta blocker and an ACE inhibitor? Because if the beta blocker doesn't work right away, you're going to add an ACE inhibitor anyway. We know that we want to get her thing down below 150. We will do that with 2 agents if you go under the general. It's also indicated that you do 2 first-line agents at stage 2 hypertension. So what is it going to hurt?
I mean, I wouldn't mind going that or 2.
Beta and
It's
an ACE.
just my rationale. I mean, if y'all want to do it one at a time, that's fine. That's just kind of what I'm thinking through. So, do we want to do the selective, beta 1 selective, or do we want to do a non-selective? I would say selective.
Selective,
You've got
yeah.
less side effects.
True.
The non-selective had the fatigue in it as well, with her already being healthy. Like we probably would have
So like a
increased the
tenolol?
risk of that.
Is there a dose,
100 mgs.
like a range or?
The dose range.
So we're doing
for
a
tenolol?
tunnel or?
No, it's
Yeah,
just
like we
100.
have with hyperlipidemia, you have like your goal, like very high intensity. Is there anything like that with blood pressure?
No.
Okay.
Not that I've seen.
That's
I
good.
mean, that's a good question.
So we're doing a tunnel 100 once daily.
I That's what I'm going with.
What'd you find?
Page 9.
Okay,
First.
summary,
B.
first line. So most patients require more than one agent anyway.
That way y'all want to do for
Yeah, I said just do the beta blocker. Wait for a couple weeks. Come back, see how it is, and then if we have to get another one on, we add another one.
When's follow up with hypertension? Does it say in there?
Just so maybe, just so we don't run the risk of dropping it too fast.
That's what I'm okay with that because of that reason.
Yeah, because that does
Dropping it
cause
too fast.
Yeah.
problems.
Beta blocker. Okay?
Just do the beta blocker. Yeah,
Oh yeah, didn't she say that in there? Like
what?
some people jump the gun and too fast.
Well, yeah, and then her pointing out earlier, she's already if she were to fall, it would be worse for this patient. So
Give me just a
fine
couple
with
more
playing it
minutes
safe.
to polish
Yeah,
up those
yeah.
answers.
You go with that, Hope?
Just do the beta blocker.
Whatever y'all got on your piece of paper, as long as it's credit. We can talk it out.
We just let her know that chances are next visit we're gonna start you on another medication.
I've done the
Or,
X
no, sorry,
inhibitor or R, but it says that that's for people who don't have a compelling
Yeah.
indication.
No, I think we have to go with the CAD.
Because she has a compelling indication.
Even though it's being treated, she still has it. So.
So what are we monitoring for?
I don't know, does Bryce, do you need the right?
Yeah, I need the right.
That's fine, it gives me time to look up.
You put Y,
Don't
right?
forget to support
Yeah,
your
patient
answer,
next
so
to
don't just write down a drug name, dose, route, and frequency, but make sure you do put all 4 components down. And make sure that you support why you chose what you did and what you want to
And
monitor.
that's the 100 mgs,
I want to monitor.
right? Once a day.
Return to clinic in 2 weeks.
What page is that on?
7.
The 2 weeks in? 7?
Yeah,
7.
it's 7. It's under 11, maintenance, monitoring, and follow-up is 8. Is it, what is it? Do you mind if I look?
And then monitor blood pressure at home.
You want her to monitor at home?
Yeah.
Why not? It's probably good for her anyway, especially with her lifestyle modifications.
Why not?
Can't hurt. And when she comes back, we want to monitor.
Well, she's probably on a lifestyle modification for the CAD, or we can still maybe
Yeah,
emphasize
because
it.
one of the things it said was she's already implementing the lifestyle changes.
Oh, shoot. Okay.
Yeah, up there. She's doing it with her brother, I guess.
We'll just emphasize to continue it.
So when she comes back, we want to check for compliance, safety, efficacy. And then do we want to ask about lifestyle changes? Oh, we probably should have put, I don't know. I was going to say dash diet, exercise, but if she's already implementing those, she doesn't want us. It's just the medications.
Should we look up any interactions between a town law and rosuvastatin?
Sure.
Probably.
Wouldn't hurt.
I think some teams are still working right now, so I'm gonna give you just a little bit more time because you're having really good discussions. So keep that going for now and be ready to talk about it in just a couple minutes.
I don't see anything.
No.
Does the Trilong come in the 100 milligram tablet? It does?
25, 50. Yeah.
So it's an offer?
I would say basing off the fact that the patient is at stage 2 hypertension, that would justify why we did 100 milligrams first.
What does she have hypertension at?
She has hypertension.
We have to start her off
50,
at 50 and
50
then take
really
her
once
to
daily.
And then if inadequate after 2 weeks, we want her to come back and then we'll increase it to 100.
Yeah, that's what micromedics says.
Yeah.
I kind of want to look at albumin levels, maybe see if her CKD is getting worse over time. I just put that down as like when she returns, maybe check blood pressure, look at creatinine clearance.
You definitely want to look
You
at
want
it,
to change?
especially with her CAD,
Albumin.
to make sure that rosuvastatin is doing its job. So I would definitely say lipid panel along with blood pressure. And then, yeah, you could do your CRCL,
80 something.
85.
Did you hear what we're talking about, Kevin? The 10 or more? Do you think we should change it to 50 initial?
Yeah,
Right.
we
What
have
are you
to
doing,
titrate. It says the initial.
I don't even know.
It's on your shirt.
Yeah, I know. I don't know how that happened.
Did it come out?
50 milligrams.
I think it's
or
leaking
1
out
to
of
2
her.
weeks.
That's micromedics.
I don't know because
1 to 2 weeks, 50 more.
It'll be alright.
like majority of the time, from what they're teaching us in micromedics is just like 2 separate things.
Well,
Like the
look
most
at
common,
lexicon
Where'd that come
too.
from?
like the most common dose is the 100.
Yeah.
But I wouldn't. What do you do?
I don't know. Somehow it's
It's
squirted.
on your shirt.
Yeah, it's squirted out of me. I don't know why. It's not coming out now.
You just need a little color in your legs.
Just a man child.
This
Give you
even says
just
take
a
your lower.
couple more minutes.
25
It's 3:18 right now. We'll reconvene at 3:20 to go
Okay.
over this.
So
As a
change
friendly
it to
reminder, we
20
are about halfway
It was like
through
Aslan
class,
went to
so make
recap it.
sure that you
Like
are
this is like-
initialing beside what you contribute. And it makes an even better case if it's in your own handwriting, just as a heads up. Okay.
So we're doing 25?
Lexicarb says to start between 25 to 50 degrees milligrams, and then after 1 to 2 weeks, you go up.
Okay, so
I said
initiate at
50.
50, just because that's the most common that we're seeing between the
Don't
two.
mean to put that in there.
It just cross out 150.
Is it 50 once daily?
For 1 to 2 weeks, so when she come for her visit, you gotta check.
That's good enough. That's good enough, right?
Initial.
Yeah, okay.
Do we know?
Maybe initial or change.
Well, that was his question.
Initial.
Oh, initial.
No,
I thought
dude,
it
I'm
was
going to initial.
Initial the
I'm going
change.
to scroll.
That's
like,
usually
we're
right
not
out
doing
the
soap
word.
though.
I made the change here.
Yeah, I mean, the soda. And then put a line here.
Yeah.
Link.
So we have to keep her,
Yes.
See, that's such garbage when he's making us memorize that stuff for the thing when it's not right.
nope, he just going by what he sees normally.
Is he making
It's
the
his world. It's hard to like trust what they say when we keep finding mistakes.
He told me yesterday after I gave him my calculator and paper, he says, go have your cold one.
What?
He gonna ask me how did it go. I looked at it.
He said, go have your cold one.
It's
That's
year
like-
20,
it's
so
just
let's
like
go ahead and go over
Yeah.
the answers, and we'll take a break after this.
Oh, good.
Okay, so this team here, what did you decide to start for LS today, and why?
We started him on a beta blocker. We put him on metoprolol succinate, 25 milligrams, PO once daily. And we chose it for the indication of CAD, because we're trying to decide between CAD and CKD have different indications for what medication to start him on. And we were kind of back and forth on which to do. But we decided, since her CKD is just stage 2 right now, and since she's had, like 2 episodes of ASCVD, to go ahead and go with the indication of CAD, so big beta blocker.
Okay, so I heard a couple different compelling indications there. You chose to only start one agent today. Why did you only choose one agent as opposed to 2?
She's only about 10 above the goal of 150, so.
Okay. So that brings up a good point. This team here, did you decide to start one agent today or 2 agents today? What did you decide to start today?
We also just started one agent today for the same reasons as that group did over there.
Okay, what did you start?
We started atenolol, 50 milligrams once daily.
Why did you choose atenolol over metoprolol?
Basically, she has refused to take medication in the past, so we like the once daily dosing.
There's this once daily.
And we also like that it was we like that it was cheaper. It's on the $4 list at Walmart.
That's good. Good job, class. Who else chose a beta blocker today? Okay, over here.
If you work there,
By the way,
there's a list.
metoprolol and atenolol, are they selective or non-selective?
Selective.
Selective. Good job. Heart just doing great. Okay. What do you guys think? What did you start for her today and why?
We did a Tylenol also because of the patient adherence, so
What dose did you use?
100 milligrams daily.
We only did 50. Why did you choose 100?
That's gonna be what we took a quiz about today. It's the common dose, I think. Her blood pressure is at 162, so we're gonna try to get into our goal, which we listed a while ago about 150, so I think it's gonna get her there faster than the 50 milligram.
Okay. I would say that 100 is probably a little aggressive, but I would also say that yes, you will get her to go faster. That is true. I can't argue with that. Who else decided on something other than a beta blocker today? It's okay. Raise your hands. Over here? Okay. What did you decide on today and why?
We chose a combination of lisinopril and hydrochlorothiazide. Basically, we did, because it's stage 2, so we wanted to do 2 different agents, and we chose an ACE inhibitor and a thiazide diuretic. And we did it in a combination pill because we noticed that the patient is refusing to take medication, so we thought that if we combined it to one, then she might be more willing to take it. And we thought about a beta blocker, but they didn't have like a beta blocker with the combination that we kind of wanted, so that's why we chose this.
Okay.
Okay, so the recurrent stroke prevention is also indicated for a thiazide plus an ACE inhibitor.
Yes. So she has TIA listed. So TIAs do fall under the recurrent stroke category, and so it would be something we would consider a thiazide potentially in this patient as well. And so when you look at her CKD, one thing to consider is that the guidelines, when you read past the recommendations part, when you read the actual body of the guidelines, it gives recommendations for CKD cutoffs. And one of the cutoffs for CKD is an EGFR of 60. So if they have an EGFR above 60, it's an even weaker recommendation. And is it an A, B, C, D, or E recommendation to begin with? It's okay. What do you think? Do you think it's a really strong recommendation, or do you think it's like a little weaker recommendation? for using an ACE and CKD. It's actually a level E, which is expert opinion, which is the weakest level. So it's really hard to make a case to base it off of the CKD for initial therapy, but I like what you had to say about the TIA being a thiazide. You'd want to consider that as well. So you could consider it for your CKD, but she's not got real bad CKD at this point, so it's an even weaker recommendation than what the guidelines have to say for it, which it didn't have a good, strong recommendation to begin with. So another thought you might make, though, is that while she has CAD, we have cardiac remodeling going on. Maybe we want to protect her from that. To make that case as well today. So I have a vote for lisinopril HCTZ combination over there. We have a couple votes for a beta blocker because of the CAD. What other, did anybody choose just to do an ACE by itself today? It's okay, raise your hands. No ACEs by themselves. Anybody decide to do a thiazide by itself?
Trying to beat you.
Oh, in the back, good. Which thiazide did you decide on today? We chose chlorthalidone.
Okay.
Because in the notes, it said chlorthalidone is preferred over HCTZ. Is it? Yeah.
Why is chlorthalidone preferred over HCTZ? You got this.
Isn't that the one that has the outcomes?
Yay!
My favorite word. Yes, and so chlorthalidone was studied in which study? I've mentioned it once before, but it's okay.
The all hat.
All hat. Good job. Yeah. It's the all hat study is where chlorthalidone was studied. But the team over there did make a good point in that unfortunately HCTZ does have the market and HCTZ lisinopril is on the $4 list and that's hard to compete with, you know? And so doing chlorthalidone by itself would have the ischemic stroke prevention because all hat studied that and that was part of its cardiovascular outcome. You could make that case today, or you could say we're going to do a combination pill. We're just going to do one pill that they have to take to get them to goal. They did mention something very interesting today, and that's that they wanted to start 2 agents because she's stage 2. What did we decide this patient's goal was, and how many agents are we going to need in order to get her to goal today? This team here. What do you think?
Well, the general approach was one treatment for every 10 above blood pressure goal. But with stage 2, they say 2, so we don't know.
So with that concept in mind, if she is stage 2, what goal would we be trying to get her to if we add 2 agents?
140.
Less than 150 over 90 or less than 140 over 90?
Less than 140.
If she's stage 2. And we're adding 2 agents.
Probably 140.
Yeah, here you go.
If you're trying to get it to 140, then that's when you use 2 agents. But since we said initially we were trying to get it to 150, as first so we can use 1 agent.
Great. Good job. And so when we look at this, 1 agent will get her very close to goal, but not quite to goal, right? So we could start 2 agents today. We could consider starting 2 agents in her. But the other case that could be made is that we just said that she's 75 and one of our frailer elderly, right? So if we start 2 agents today, maybe she's going to respond really well to those 2 agents. She falls and breaks a hip. That's not exactly the best case scenario, right? So when we think about how to start a medication regimen, whether or not we want to start 1 or 2, we have to consider what the patient's baseline goal is and how many agents you want to add to get them to that goal. For the purposes of the exam, it'll be much more straightforward and clear. They'll have like a blood pressure that's within the goal, and so you'll know how many you need to add for that. But this is for the purposes of discussion, how many you should add for a patient that's right above goal. Because remember that being stagnant on hypertension is something that plagues all clinics, right? They come in and we don't treat their hypertension, we treat everything else, but we don't treat this, and they end up with TIAs and things like that going on. So, okay, keeping these things in mind, we'll hit some key points and then we'll take a break. Question? Oh, what do you think? Dose dependent? Yeah.
And you have to use the lowest dose. That's why we went with 2, because we know the goal that we used 12.5 on the HTC.
Great. So when we say 10, that is a maximized agent. So that's the maximum benefit that that patient can get without experiencing side effects. It's usually around 10 is what you're going to get. Now, some people are going to respond super well. There's actually patients out there that are, they have issues with their renin-angiotensin system, and if you start an ACE inhibitor in them, man, their blood pressure will plummet. It's amazing to see what just a small dose of ACE inhibitor can do. And you'll have tried everything in those patients, and then you try an ACE inhibitor, and they go to goal almost immediately. And you're going to have those random cases, but usually you have to optimize one agent first. Keeping that in mind, in this particular patient, because she is older, you would want to start at a more conservative dose to start with and work your way up. Because again, our primary concern in her is preventing falls. So good thought, good thought. Okay, and one thing that we didn't hit that I did want to mention is that what specifically with a beta blocker would you want to monitor in this patient? What vital? Her blood pressure, but more specifically what?
Heart rate.
Her heart rate, right? So if you have somebody who is borderline bradycardic, you don't want to start a beta blocker in that patient, right? Because it's going to push them into bradycardia. Same concept we were working with before. So if you have a patient that has peripheral edema, you don't want to add the non-dihydropyridine because it's going to make it worse. You know, same concept that we had before. Also, when we look at our other agents, we talked about ACEs and hyperkalemia and incidental CKD that can occur there. So always be thinking about what you might want to be monitoring with your patients. We talked about hyperkalemia with ACEs and ARBs. We talked about hypokalemia with thiazides. So just like with your triglycerides, you had to keep straight which agents made those go up and down. You need to keep straight which agents make potassium go up and down in your blood pressure medications. Okay. So, general rule of thumb is one agent for every 10 millimeters of mercury above blood pressure goal. Remember that it's chlorthalidone that has the outcomes data. Remember our main 4 that we can do in essential hypertension, and that we usually start with an ACE or an ARB, not together, and then we add either a calcium channel blocker or a thiazide. However, this was a patient that had compelling indications, and we've talked about most of these already, but a beta blocker makes good sense, right, in an MI or CAD, because we're relieving the pressure that's within the heart, because that's what's causing this to happen. It's ischemia within the heart that is occurring, so we're going to make the heart not have to work as hard and dilate those vessels a little bit, make sure it's not pumping as hard as it used to be, and that's going to help that patient out. And so that's going to be the beta blocker for an MI and CAD. Diabetes, remember, #1 cause of renal disease in the US is diabetes. So if you remember diabetes, you've got CKD down as well. For recurrent and ischemic stroke, remember ALHAT is where we get that one from, and the chlorthalidone has the data behind it. And African Americans have been studied specifically for calcium channel blockers or thiazide diuretics. Here we go. No. Okay, just like no, I just want to get to break. I know. Notice we don't have ACEs and ARBs up there for African Americans. Why is that, this team here?
All I know is African Americans don't respond as well to ACE inhibitors.
Okay, so yes, they don't generally respond as well. That's true, but there's something else that, yeah, side effects. Which side effects are more common? Here you go. Angioedema. Angioedema related to what? We've talked about this before. Angioedema related to what substance in the body?
Bradykinin.
Bradykinin. There you go. So you can have an increased risk of that. This is more common than you would think. This does occur, and so it's something you need to keep in mind. And with that, we'll go ahead and take a break. We'll reconvene at 1:45.
Okay, so what did she say about that?
Angioedema.
Right.
To increase
And
bradykinin.
Oh, to increase bradykinin or in response to it?
I put it leads to increase bradykinin.
Just like that.
I'm an extortionist.
You just get money from random
People just like me.
I wrote that because it's something I'll actually go back and research and then read around it. Because they like to ask the mechanism of action.
That sounds pretty good.
Pretty much.
I got this coupon thing I gotta use today.
I gotta go to the bathroom first.
That's how they get you, man.
Dude, it's $3 off a $5 bowl.
What?
So it's like $2.
This is a pretty decent deal.
Yeah, dude.
That's a good coupon. What I said?
Do you have T-Mobile? Is your T-Mobile as your service provider? You do? Download T-Mobile Tuesday. It's like you get free stuff all the time.
Oh, really?
Yes.
Okay.
Do it. So right now the deal is, if you go to Panda Express, it's $3 off anything you buy for $5.
Oh, no shit. Okay. You saying something Tuesday? I need that.
T-Mobile Tuesday. If that's your service carrier.
Yeah, it is.
They, like, in the past, they gave you, like, $2 Dunkin' Donut cards.
No shit.
Free Redbox movie.
What?
Yeah.
Verizon just charges you.
Pretty much a free shit on here.
That's all they're good for.
Dude, they gave a free month subscription to, was it Study Blue?
Oh, really? That's cool.
Yeah.
So you can find
I
everyone's
missed
like
it.
stuff they post.
I know. I missed it.
Wow.
I missed out.
The fact that this shit is real is just hilarious. You know that when you get your clothes cleaned at the cleaner, you know that bag they put over your clothes? Look at this shit. $700. $700 US.
So she's not wearing a dress underneath, or is that a dress underneath?
Yeah, she got a dress on the front.
So is that supposed to be like a wrinkle?
This is it right here with nothing on the bundle. That's what you buy for $700.
Oh, I got plenty of those. You want some?
I got some off.
I would charge you $700.
Let me see what it say. It's called a dry cleaning overlay. You must be out here. Dry cleaning mine. Here it is on the runway.
Alright, has anybody heard any drama going on in the school?
No,
Is that the first years?
No.
I don't know what's going on. But there were two guys up there talking to an admin. And when I was walking out, I heard he was really upset and I was trying to calm him down. But they were talking, it was two students separated talking to an admin who was taking notes. So I don't know what happened, but it sounds like someone got into a pretty heated conversation or maybe even a fight. I have no idea. So I wasn't sure. Has anybody heard anything? Is anybody
arrested? At the school?
Oh, there was a girl. Yeah, she stole a wallet, credit card theft. Yeah, someone stole a wallet, and it was 2 weeks later they caught her, and it was in the class. They came to arrest her.
At school, they came to get her.
Yeah, that's why you weren't allowed to go out over here. They had it shut
Yo. Hold on, people be taking credit cards? I'm gonna stop bringing my wallet to school.
Well,
Okay, it's quarter till,
left
so
it
let's
on
go
the
ahead and
table.
get started back.
The guy that lost it, but yeah, I know.
Through the next
$700.
For the next application,
Yeah.
we're going to look at Lando. So what if Lando had stage 1 hypertension and diabetes? What would be his goal blood pressure? Be sure you support your answer.
Is this
And
a
what
new case?
agent would you choose? And be specific with the name, dose, route, and frequency.
Is this a new
Okay.
case?
Yes.
Wait, were you here when it
We'll
happened?
reconvene at,
But when I
we'll
went
see
to
how you're
Marion,
doing
one of the
at
first
5
students
till.
was telling me about it. And then we're both first year students, so obviously something's going on with that class.
It is. 10 of them didn't make it from the first session.
I know, and that's what I was telling them, like, that's going to be one of the easiest.
Is this
they
Lando
picked
Calrissian?
and Pearson, the two easiest teachers.
Good old Lando.
That's what I was telling them, like,
Let me
so
zip my
granted, they
shit up
only
right
had men and him, and so I'm sure it was really difficult, but those are the two easiest teachers we got.
Kashawn didn't either.
No.
He was easy. I've seen the stuff he gave me. It
Well,
was
how did you
easy.
get that? You got all this candy. You're gonna make me break when you get
I'm scared. I gotta zip up all my bags. Gotta check my pockets at all times.
Oh, because there's a piece about.
Yeah.
No, I'm not gonna eat your candy.
I know, I'm getting afraid to leave myself in the room now.
Actually, no, I'm not. I'm gonna sit here. I'm gonna eat the fucking apple.
Dude, like 2 years
Be
ago,
healthy.
I would leave my stuff and go away for like 3 hours. And
I'm
come
gonna
back.
be good.
And I know it'll still be there.
Gonna be good.
Now?
I probably will get home and I'll eat half a bag of candy.
Let's turn that thing on. Don't.
What if Lando had stage 1 hypertension and diabetes?
How old is Lando? Is he
I don't
old?
know.
We don't have an age. We don't have a.
No, them.
So would he just be 140 over 90?
Well, it
less
would
than
just be the
130 over.
diabetes. It would
Less
just
than 130 over 80.
yeah. It would have to just be the diabetic
Agree?
thing on the
Everybody
chart.
agree?
You gotta go with the ARB. Wait, you can give ARB to African American, right? You just can't do an ACE.
You can't do ARB.
You can't do ARBs either? They do the same thing?
No ACEs or ARBs.
Oh. I guess the calcium channel blocker?
You have to start with or CCD.
Or thiazide?
ACEs. Well, we said we can't do ACEs. We didn't specify whether we can do ARBs, but I'm assuming that Kevin says it's the same. It's not written anywhere in here.
You'd start off with CCD or hydrochlorothiazide.
CCD or thiazide. That is. But then look what it
What
says.
page is that?
No, I took a picture of her last screen. But see, in her book, it say on page 6. You come back with the ACE or R. Only applications are stabilized. Only initiated after it's stabilized. And that's because of the side effects, I guess.
Okay, it's on page 6. If you need to know. It's one of the special groups, the compelling indication. Yeah.
So girl, I can imagine in my head what girl it was. I didn't realize my name was missing.
How long ago was that incident, Alex? I can't remember.
I don't remember.
The book getting stolen? The book getting stolen?
Not about this. We were talking about drama with keywords.
Drama?
The girl got arrested in the class at the school because she stole a guy's credit card. She stole his wallet from the classroom, and they found her 2 weeks later because she committed credit card fraud. And they came up here and arrested her.
Wow.
She can't, yeah. Well, I would hope so. If they didn't, I'm going to be pissed. I'm going to be raising some cane. But anyway, and
Raising
then...
some cane, is that what you just said? That was creative.
But anyway, and then when we were up there, did you overhear any of the conversation that was going on between the dude and the admin person that was in the student center? Well, what I heard when I was walking out was him telling the admin person, it was 2 P1s, he had them separated. He talked to 2 different ones. But the second one I heard as I was walking out was talking about a situation and this student that he was trying to calm him down because he was getting really upset. And so I don't know what it was. I was asking if they had heard anything because they were having to talk to an admin, so I don't know if a fight broke out or what happened. But it sounded pretty bad.
Oh my god. Can't handle school, how are you going to handle anything else?
Yeah.
Good lord.
Chelsea and Cannibal.
I've never once wanted to like fight someone over anything. It's crazy. I mean, I have, but it takes a lot. Like, it's not going to take like education or like me failing a test or a teacher being a douchebag.
Exactly. So, I mean, I don't know. That's just what I heard, and so I don't have any other information.
That's embarrassing.
Which one was on my therapy? No.
There's no excuse for that. There's no excuse for that. Behavior, like stealing stuff, trying to fight.
I don't get it.
So, do you want to go with your dad?
I mean, I really just don't get it.
Where's my...
I don't either.
Am I right on the back of it? No, I'm right on the front.
So which calcium channel blocker are we going with?
Stage 1? Yeah.
Wait.
I don't have that chart.
So what does that asterisk mean? So why is he not less than 140 over 90?
Why is he
without stress? The F tolerated without undue stress.
It's above it. You see that?
So what does that mean though?
Exactly.
The asterisk is basically saying your goal is less than 130 as long as that's okay for the patient. If it's stressful on the patient, if the medication, if they're not handling it well, you need to reassess your goal.
Well, he's already stated.
It says that you can tolerate it without excessive.
So he's
140
140
to
over.
159. So take him down to 130 because if he's already most patients less
That's the
than
thing, we don't
140.
have his blood pressure. We don't know.
Yes, we do. He's stage 1. He's
Yeah.
between 140
So,
and
so
159.
he could be at least 140.
Yes. So if he's already there, why even
But he's
start
not
there?
there. It's less than 140. So it could mean 139. It could mean 138.
That's the goal. The goal is
The goal.
to get him to 139, but right now he's at least 140. So what if he is 140 on the dot? What's the point in initiating therapy to get him one number under?
Well, that's what I'm trying to ask. Why not that?
What's his blood pressure at?
Are we not doing 130 over 8? Less than 130 over 8?
That's what I wrote down. Yes.
I think he's 140 to 150 or 90 to 99.
On an agent at 130, so I would say change your diet.
Oh no.
I mean, if I just need to get you down 1 point, but she didn't ask what modifications can we make. She said, what agent are you going to choose?
Probably 140.
Since she wants the medication, give her one.
All right.
I'm honestly thinking it's 140.
That's how I thought.
Yeah,
Based off
you're
the
gonna
general.
need to give it because I mean,
It ain't no point.
but see that's the thing. It's not in the 130s. You want it less than 130, so you want it in the 120s. You're gonna have to initiate therapy anyway.
Get him down to at least 129.
Exactly.
We don't know what he's at though, so it's like kind of weird to me.
It is kind of
So
frustrating,
it's
but
probably going to be too low.
I don't know. I'd say just start with the calcium channel blocker.
It says with this group of African American patients, it says to when they stabilize, you can add something else.
What age would you choose?
I'm just thinking one.
What are our options on the calcium channel blocker? I didn't print that out.
Under 140 as the goal. Is that what you're
Is
saying?
that what you're choosing? A motive?
Is there one that's
These work on the heart. Non-dihydrohydroquines work on the heart, but we don't have anything to go off of to say heart.
Besides him being diabetic, there's nothing in there that
Oh,
covers
is
anything.
he diabetic?
Yeah.
Oh,
It said dihydropyridine
yes,
preferred.
He needs a non-dihydro.
A non-dihydropyridine?
Well, no, because cardio, he's at risk for cardio problems, right? With diabetes.
Yeah, he's already got
Oh gosh.
Diabetes, so ACE or R. Yeah, that's what he's saying right here. ACE or R, then add calcium channel. But I think the African American trumps.
Bill
Can
too.
we give them A's, but can we give them R's? But they're gonna reduce our heart.
Okay, we're not doing beta blockers.
No.
Anyway,
We're just
so
doing
we're just doing calcium channel. So
Why did she do
I prefer for hypertension.
the
for
pulmonary
these
edema,
agents
right?
reduce-
Or peripheral.
Heart rate.
So does R?
And see, we don't
So
know
we're
what
not
heart
doing
rate.
extended. Do they not have them with non
Can we not give them carbs?
No, African American.
So we can't give them A's or carbs?
For initiation, you have to either do a CCV or thiazide.
It's on, if you look
It's
at
that
under on
last
page 6.
slide. Look at her last picture of her last slide. Oh, and
Page
page
6, that one, African Americans, you do calcium channel blockers or thiazide before you do an ACE inhibitor or the R.
So which one?
It just says lower strength the recommendation to start with 2 things. But what if we just do one calcium channel blocker? That's it. Just goal 140.
Let's look at the difference between non-dihydro and dihydropyridine. Because if he has diabetes, he's at risk for cardiovascular events. And with that being the case, the non-dihydropyridine work on the heart.
Dalteosm works on both.
It'll work on both, but that's as far as I know. I don't know
The
what to give him yet.
guidelines, it says thiazides, like JNCA guidelines, it says thiazides are better to protect the heart than
So go with the thiazide
CCBs.
than the CCB?
Yeah.
So should we do that Kana whatever thing? Chlorothiazide or chlorothiazide?
Okay.
Or that, I can't say that word.
This is a weird question. I'd be like, Sir Lando, can I take your blood pressure, please? Even though I'm not supposed to base it off of one blood pressure reading. I mean, we know it's somewhere between 140 and like
Is the syllabus right? Is Romero teaching us tomorrow?
Yeah, somehow.
Or is it her? Because on here it says 2nd, 7th, and 8th.
Oh, it's because she has like the first half of tomorrow.
Oh, it's
she
split
sure
in two?
does.
Yeah,
Okay,
Did y'all understand any of the EKG stuff yesterday?
No.
I had no idea any of the words he was saying.
Me neither.
I was like,
I got a 1 out of 5 on that rap.
Yeah.
Just so
Give you
y'all
a
know.
couple more minutes to polish up those
Yeah, the
answers.
two.
Reconvene at 4 o'clock.
We got a 3 as a
You
team.
got a 3 out of 3.
But did you see the average for the class?
No, I
It
didn't.
was a 2.5.
Oh, that
Ooh,
makes
I
me
don't
feel a
feel
lot
too
better.
bad. I'm right there. Right with the average.
I just think it's hilarious how he keeps talking like.
Make sure that you initial beside what you
We just want you
contribute
to know the
today
generic
and
lines
sign
need a
it.
drug.
And
And also
I
make
thought
sure
y'all
that
were
you
gonna
put
put
down
that
not
out.
only the
Knock
goal,
that out
but
of
why
the
you
park.
chose that goal.
yeah, and he was like, he's like, y'all knew it doesn't measure contraction or something. I don't even remember what he said.
I can't.
I was
I
like,
tuned
where
it out.
is that in the video?
Yes.
Hey, we need a drug, guys. Chelsea Cam blocker.
I say just pick one.
You'll two of them?
Yeah, I mean, we got a whole list. Why not? Here, let's do this.
It's a
And
non-dihydropyridine,
it's an
and
extended
it
release,
works on both the
so
heart and
then
the
it
vasculature.
covers him throughout the day. He's African American.
Which
That
one?
was the
Did you say diltiazem?
The non-dihydropyridine.
Diltiazem? Is this the
Uh,
I don't.
I don't understand. She asked us why.
Diltiazem?
Because it has an extended release. Is there another one too?
Procardia? See? When she asked
Well,
why.
we'll just say it protects the heart. It's specific
What's
for the
wrong
heart.
with amlodipine?
Amlodipine is a
That's the
dihydropyridine.
dihydropyridine. It's not the non-dihydropyridine. And so that's where we're trying to figure out the
And why do
difference.
we need a non?
Well, this one targets the heart directly. This one targets which one?
Oh, but I could start here, so we must start here.
Well, just go in, Lucy. I'm
Amlodipine.
fine with it. Do it.
How old is Lando?
We don't know.
Want to know. There's a CBD risk.
And that is 10 milligrams. We need to look that up.
Yeah, we need to look that up because it says we got a range right here. It says 2.5 to 10. So I don't know if this is another one that we need to titrate up. Might go back.
5 milligrams oral daily. Titrate max to 10.
Sounds good.
My bad, was I playing footsies with you?
I'm not in here for that.
That was the table.
Man child.
I was gonna like put my foot on it and rest it.
Can't do anything today.
I got
Did we not want to
you.
do the thigh side?
I don't really know what to do here.
It's up to y'all.
Well, he said the guidelines said thigh side for African Americans, right?
Yeah. It protects the heart better than a CCB, but otherwise everything else is the same.
I just texted him. Did you
Okay, so let's go ahead and get started back.
I did one this morning.
So over
I didn't get a
here,
response from him. I think he's great.
what goal blood pressure did you decide for Orlando today and why?
Then we're good.
The goal we said less than 140 over 90. Stage 1, let's see, stage 1 hypertension indicates 140 to 159 over 90 to 99. If there is no undue treatment burden, then wait, what? Then less than 130 over 80.
There we go.
Nailed it. When it all falls apart.
So the normal, stage 1 is 140 to 159 over 90 to 99. So we want to go below that, below 140. But since he also has diabetes, we don't want to do an undue treatment. So, but you could do 130 over 80 with that.
Okay. So how many teams put 140 over 90? It's okay, raise your hands. What about 130 over 80? Everybody else. Okay. So what made you decide 130 over 80 as opposed to 140 over 90? This in here.
According to the chart, because he has diabetes as well, it's indicated for goal as less than 130.
Okay. So she says because he has diabetes, we want to go with 130/80. What would make you choose specifically though, because diabetes is also indicated for 140/90, right, per the guidelines. That's a pretty strong recommendation. So what made you decide to go lower in this particular patient?
He can tolerate it.
He could be at 40 right now.
I mean, really, yeah. You don't want to initiate treatment if you're going to drop it down at one.
So, like she said, a simple lifestyle change will get it below.
Yeah.
Not if you don't need a drug.
That's a good point.
He could actually be at 140 for stage 1, so it would make sense to be less than 140/90.
Right. So when we think about setting goals for patients, it's always individualized, right? Based upon the information I gave you, it's very limited here. So you could pick either one of those and it would be correct. The key is how you're supporting it. So if you went for a higher goal, you might say, you know, there's some gray in his mustache. Maybe he's older. Maybe he's older and we just want to go easy with these goals and we want to see if he tolerates 140/90 before we go to less than 130/80. Now some of you also are saying, well, he has diabetes. You're saying that he has diabetes, so he's at high risk of complications, and if he's at high risk of complications, then we want to make sure that his organs aren't taking a beating. We want to make sure that we get that lower than 130/80. So keeping these things in mind, Team 18, what did you decide today?
What was the question?
What did y'all decide to do today?
We decided to give a calcium channel blocker and Modipine 10 milligrams, one tablet 5 months daily. And we said because we noticed he was African American, so we decided to give a calcium channel blocker, and ACEs and ARBs are not first line for African American patients based on G and C8. Technically, any of the first line agents can be used for diabetes.
Wonderful applause. Good job. So when you look at the guidelines in JNC8, they say that any of your 4 major groups can be used in diabetes. The reason that we tend to prefer ACEs and ARBs is because diabetes is the #1 cause of renal disease in the US, and so we're adding it on board early is the thought behind that. But per the guidelines, technically you can use all 4 and he has compelling indication. So it's a good thought, a good thought. What other teams decided to start a calcium channel blocker today? Did anybody choose something other than amlodipine? Up here? What agent did y'all choose today?
Diltiazem XR120 once daily.
Okay, so what did you decide to
The risk of edema was less with diltiazem.
Okay, so they're saying that the risk of edema is less with diltiazem, which is correct. So keeping that in mind, what teams picked amlodipine? Come on, it's good. Up here. What, you're putting your patient at risk of edema. Why didn't you choose to put him on diltiazem? What's wrong with you?
But we don't know if he has any history of edema or something.
Oh, you don't need it.
I mean, it's not about it.
You don't need a risk of edema. Pick it up.
Right, okay, so when we think about these things, possibly he has a history of edema. We don't know that. Maybe he does, maybe he doesn't. A thought behind why we might want to avoid diltiazem or a non-dihydropyridine is it could cause a decrease in what? Our non-dihydropyridines work on what organ? The heart, right? And if they're working on the heart, then we're going to see a decrease in which vital? Heart rate, right? So if he's already a little bit bradycardic, we wouldn't want to add that if that was the case, but you didn't have that option, so either one of those would be fine in this particular patient. Did anybody choose something other than a calcium channel blocker today? It's okay. Up here? What did you decide to choose, Dad, today? So we have a vote for an ARB up here. One of the teams, maybe back here, why did you not choose an ARB in this particular patient? Why did you go calcium channel blocker instead? If you went calcium channel blocker. Let's see, what did you choose today?
It's not indicated for African Americans.
Can we just not use them auto ever?
I have a question about that, because from what I read, it was only mostly with the ACE inhibitors and mostly with lisinopril itself, so.
It's a great thought. Here we go. What do you think? No, it's good. At least ask your question.
Yeah, I was asking what's the, because from what I read, it was mostly with the ACE inhibitors and not the ARB, so if you would give him an ACE inhibitor, like, in what conditions would you consider ACE inhibitor?
Great. So when you think about it, you would prefer, if you had to use one of the two, you would prefer an ARB over an ACE, but you would still prefer a calcium channel blocker or a thiazide first because they have better outcomes in general. And so you're actually doing more benefit than just treating their blood pressure in that case. It's a good thought though, really good thought. Well, you could, good point, yes. And so with diabetes, you can use any of the first four, but thiazide diuretics do increase your risk of glucose intolerance just a little bit, that's true. Even though we do have good outcomes with diabetes and thiazides. Good thought though, good thought. Okay, so you all kind of all picked up on this next key point.
My Zen moment over here.
Have a thought over here? Have a thought over here, what do you think?
We just thought that starting with 10 milligrams would be the best choice. Because they said they could throw 10 milligrams to someone that haven't taken blood pressure medication before, and some 140, between 140 and 159 for stage. So why would they make the choice of giving 10 milligrams instead of starting amlodipine has 2.5 and 5? Why 10 milligrams?
Okay. So, repeat, I'm sorry.
Okay.
That's how we all feel.
They initiated 10 milligram amlodipine. We just don't think that would be a proper clinical judgment, seeing the patients haven't started blood pressure medication before.
Yes, okay. I'm with you now, Okay, so somebody that put down 10 milligrams of amlodipine, it's okay, raise your hands. Over there? What made you decide on 10 instead of 2.5 or 5?
Based on two clinical trials, that was the normal dose, and that's the one that's been tested to decrease the hypertension.
Okay, so we have a vote for it's a clinical trial dose. What else? Somebody that started 5, raise your hand. Did anybody start 5 today? Over here? What made you decide on 5 instead of 10?
We kind of went with the side of caution to see if the 5 would do it and then move up to a 10.
Okay. So either is a valid option. One thought would be to start him on 5 and have him back sooner, just to check and make sure that he is getting to goal with that 5. Odds are we will need to increase him up to 10, but 5 would be a good starting dose too. Or you could be like, okay, we already have a pretty high goal of 140 over 90, or we just want to see how he does with 10. And so you could take that approach too as well. Either would be okay. 5 would be a more conservative approach though, that's for sure. Good thought, good thought. Okay. And so when we think about these things, we do have some key points. And so African Americans with diabetes, a calcium channel blocker or a thiazide is still preferred because we have better outcomes when we use these agents in African American patients. And I had a great discussion up here with this group because I'm thinking they did some research on this actor, and he actually is only half African American. So what do you do in that scenario? Well, the answer?
What's he half of?
Half of these.
The answer is we don't have the data for that right now. The more conservative approach would be to use a calcium channel blocker or a thiazide because you're trying to prevent side effects, right? But another thought would be maybe we could go ahead and start that HRR. We're not sure at this point. But the key thing that I want you to take home from this, other than the fact that you need to use these agents and these patients, is that in future recommendations, there's gonna be more genetics involved. That's gonna be something that's coming in the future, is gonna be based upon genetics. We already have some guidelines available that are pretty global. They use global terms like African American and global terms like Asian American, that kind of thing. But it's getting down to SIP chromosomes and that kind of thing. We have, Dr. Jones has the pharmacogenomic selective, and there's already a whole list of meds that have pharmacogenomic indications. We're getting down to that level. So keep this on your radar for later, because this is the future. This is where we will be headed eventually. Okay.
Sounds interesting.
So we'll come back to that key point here in a second. Actually, we'll do that right now. Okay. So for your next one, you need to write down an example drug regimen that would indicate a patient has resistant primary hypertension. And then name 3 medication classes that could be added to that regimen to get the patient to goal. So provide an example of what would indicate resistant hypertension is present, and then name 3 medication classes that can be added to get them to goal. And it's just a class. You don't have to name specific agents unless you want to.
They already graded our quiz today. I wish they would grade our test.
I was talking about that outside.
It's graded. Lana, they don't let us test graded.
They graded our quiz?
You can do whatever you want.
Apparently.
Me too.
Put your hair down.
I guess isn't it like exact?
Covering up the camera.
Okay, so we just need more than 3. We just have to come up with one. It says they have to be on more than 3 antihypertensives, and 1 must be a thiazide.
Provide an example of regimen that would indicate resistance.
So I mean, you could do the hydrochlorothiazide.
ACE and CCP.
Let's just take it off of our list here. So we got hydrochlorothiazide. I just redid the chart and wrote it out. So 25 mg by mouth daily.
Hold on, she's writing quick.
Oh, I'm sorry.
So these are the examples?
Yeah. Okay. It's on page 8.
Page 8.
What is it?
Okay, so just an example drug regimen: hydrochlorothiazide, so HCTZ, 25 mg by mouth PO daily, and then
Number 2.
let's do. You want to do an ACE inhibitor?
Yep.
Just do the lisinopril. It says one of them has to be a thiazide diuretic.
Yeah.
But the study is behind the other.
No. It's saying just come up with a random drug regimen that would indicate that they. So it's just one right now.
It could
This
be
is what you
any
do when
three.
you switch it. Like that'll be one of our medications that we add on.
Lisinopril 10
Yeah,
I
by
thought you were
mouth
like slowly
daily.
giving up.
So we got an ACE inhibitor, we got a thiazide. What else?
I mean, I caught up with sleep
I
last
mean,
time.
you don't want to do
Can't do an R.
So non-selective beta blocker, you want to do propanolol?
Oh, man. I was starting to get sick yesterday, too.
Propanolol, 40 mg by mouth.
Still took the
twice
test,
a day.
though.
Yeah.
And no law.
I wish I could catch up on sleep.
That was my first time in like a long time. actually got a full amount of sleep.
Okay, so there's 3 meds.
I haven't even been on
But
a
it
similar
says,
hours yet.
yeah, okay, so of the 3 meds, one of them just has to be that. So there's our drug regimen.
Yep.
And then you could add an aldosterone antagonist. It says are highly effective add-ons.
Yeah.
So
Add the class.
I guess it would just be those 3 right there. Just the 1, 2, 3. Because those are all classes of medications, the thiazide, the antagonist, and the loop diuretic would be the 3 medication classes that can be added.
On top of the hydrochlorothiazide, the cinnamon propranolol?
Yeah, that's what I'm trying to think. You can add another thiazide on top of it.
Well, that's what I'm wondering. It doesn't really talk about it. It just says that those are the 3 classes that you could add on.
Are there any adjunctive, like...
We got this.
I mean, I don't think it's saying you do add it on.
Okay. So they're 2 separate questions, basically.
Yeah.
But
But no, that doesn't make sense because it says one of yours has to be a thiazide. So one of the 3 medications that indicates resistance has to be a thiazide. So I guess you would add a second thiazide if the patient still has issues. But I don't know in what scenario you would do that. Like, I don't know how that works.
Aldosterone antagonist?
Beta block. Right? Why would, okay, so do we need to add one just to cover all of the classes?
No, it's
Chlorothiol,
just 3.
Yeah, it just says
Greater than or equal to 3.
Yeah. And of the 3 medications, one of them just has to be a thiazide diuretic, which is our HCT.
And then 3 classes that we could be adding are thiazide, aldosterone antagonist, and loop diuretic?
Yes.
Yeah.
What's the benefit of... Okay, so we got 3 drugs, right? What was our benefit and purpose of choosing these 3 drugs for this patient? Whatever
They need to
the case
do
may be. This would have
blood
been
pressure
for
monitoring
fluid,
at
right?
home, apparently.
Lisinopril would have been because
It's the ACE.
and
It's first line defense, and ACE and ARB is first line. So first line didn't work, so we added another agent, which
so we picked lisinopril from those because
just because
We
it
could
was
have
on
picked
the
any.
list, we could have picked any of them, yeah.
so what was the benefit of picking lisinopril over any other?
But we don't have a patient, so we don't know.
Yeah, we don't have nothing
It was
to
just
go by.
make up a made up regimen.
That's what I don't
Yeah.
like. I could have wrote 3 drugs down.
Yeah, that's what we're doing.
That's all she wants.
But
to
you
do.
can't put an ACE and an R.
So that's one thing
I like about this application.
Oh.
Because this ain't gonna be no test.
Well, not necessarily. So you got to think about it this way. You have to. So one, we have to know our medication classes. 2, we have to know which medications are in which class because, like you said, you have to
So
be sure
what
that
is
you
our
don't add a
benefit
base
for this combination? What is our benefit? Even though we don't have a patient, what is our benefit? We know what the guidelines say. We know they say it has to have at least X, Y, and Z. But what was our benefit to the patient for being the pharmacist recommending these 3?
They were just trying to get them the goal, but they failed basically.
Okay.
So that's what resistant
We started off with
hypertension
the
is.
ACE inhibitor because most of the time, no. Lisinopril would be first. We're just listing medications.
What would we have said? Okay, this is what I want to do first.
First, we want to start the ACE inhibitor. Okay. So there's our
And then that
lisinopril.
didn't work.
Yeah, that didn't work. So
Okay.
then we're going to add the hydrochlorothiazide because it's a thiazide. It increases output and all that other stuff.
And we went for a beta block because
It just probably didn't work even with the thiazide. So now they're on 3 things. It still hasn't worked. They're like, what do we do now? And now we can add either thiazide, aldosterone antagonist, or the loop
We
diuretic.
could even add a 4th one if we wanted to.
Give you just a couple more minutes to polish up those answers. I think most teams are closing the loop on this, so just a couple more minutes.
And then have to monitor their blood pressure at home.
we watch out for hypertension, right?
Yeah.
It seems weird to me to be on 6 different drugs. I don't know. The possibility of being able to be on 6 different medications for your high blood pressure is insane.
Actually, a lot of what I've been hearing just around town, a lot of what I've been seeing is most people are on at least 3, and in order to control it. It's well controlled with the 3, but I know most of them are on at least 3 blood pressure medications.
Yeah. It's just crazy.
Yeah.
It's a lot of medicine.
Right?
No hypo or hyper?
Well, that's why they do like combo drugs. Like a low hydrochlorothiazide with simple hydrochlorothiazide.
Guys, I got a 10 out of 10. Y'all don't know how exciting that is. That is the first 100 that I have made this session on one of those stupid rats. Oh, that is so exciting. Go tick.
The test is ready too.
The test is ready.
It is?
Oh, you know it is. It's not on there.
Oh.
Oh.
It can't be graded because there's stuff we have to write and they have to manually grade it.
There was that one question.
You get a raw score. That's how why he was so pissed off that day when we all failed the racks. He watched them as we turned them in, sitting up there. You know that day he was pissed off. That's because they watch the grades as they come in on the computer.
Oh yeah, but they're all A, B, C, or D. They're all multiple choice. They weren't.
You still get a raw score though.
Oh.
They get a raw one, even if it's some fill in the blank.
So then those don't count?
Yeah, they count, but it's raw because they have to go back in and add the points. But it don't change that much.
I hope it would.
Somebody has to take it.
Brandon, what did y'all say for that one that she was asking? I said
Which
one, you
one?
can't adjust the doses, the advantage and disadvantage of combination products.
I just said it hits one receptor, even though it can hit 2. It can only bond one at a time. Yeah, I give like way more than 1 or 2.
See, I wasn't sure what she. I thought she was talking about like combo products.
Because I was also thinking, well, you might have more side effects because you're getting 2 different receptors now to treat one thing.
One of the things I said is you can't adjust the dosage of one.
I said compliance is easier to deal with.
And that's another thing I said, you could increase patient compliance. Okay, that makes me feel better. Huh?
It was an opinion question.
Yes,
That's
it's
kind
your
of what I
opinion.
thought, but I wasn't sure. You know, she scares the bejesus out of me.
You're gonna grade my opinion?
Dude,
Your
wow,
opinion is
that's
wrong.
my opinion. I don't have any scientific evidence to back me up.
What's your opinion on that? Wrong! Okay.
I'm
That's what we were
paranoid right
talking
now.
about.
That's weird. Or she's like, your opinion's right. You win. I don't know.
That would be my argument if she's like, you got it wrong. I'm like,
Well, that's your opinion. And your opinion's wrong.
my opinion is how I'm right.
Yeah.
Okay, so let's go over these together. It's okay if you're still working. It's okay.
Not yet.
So this team here,
Oh, what did I take?
how do we define
so no good.
resistant hypertension? Patient is on greater than or equal to 3 antihypertensives, and one of them is a thiazide diuretic. Right. Okay, so we've got 3 meds, and one of them's a thiazide diuretic, and the other 2 at least are on board, right? That's our minimum to start out with, and we've maxed out those agents. So for example, what regimen did you all provide?
Lisinopril 10 milligrams, PLO daily, and Lodipine 5 milligrams, daily, and chlorothiazide 12.5 milligrams, daily.
Okay. So they decided to go with an ACE inhibitor, a calcium channel blocker, and a thiazide. In this particular regimen, this would be maxing out our first-line agents, right? Because we wouldn't put an ACE and an ARB together. So this would be somebody with essential hypertension. Could you also see a patient that potentially had a beta blocker on board, this team here?
Because I mean, technically, you could do CAD.
So could they potentially have a beta blocker on board with diagnosing resistant hypertension? Yeah, there you go.
If they had a compelling indication, for example, coronary heart disease.
Yeah. So they could potentially have a beta blocker on board in this scenario as well, just depending on what their compelling indications are. So when we look at this, your average primary care provider can treat hypertension broadly, like we've been doing, pretty well. Like they can do that. This is where you're going to get consulted. What's in the bottom of the barrel? What are our other options that we have? What are some of those options? Name me one, this team here.
Thiazide.
Okay. What if it's in our definition? Are we going to add another one?
We're gonna change it to chlorothalidone.
Okay. So we're going to change the chlorothalidone. Okay, that's an option. What other drug classes do we have though? This team here.
Aldosterone antagonist.
Okay. What's the what? Say what? Yeah. So spironolactone, and what's the other one? Eplerenone. Good job. Are these what type of diuretics are these classified as? This team here.
Diuretics. Oh, okay.
What type of diuretics are these classified as?
Spironolactone is not preferred though because of sexual side effects. Plurinone's the ototoxicity. What's the other one?
Potassium spironolactone.
Great. So with an aldosterone antagonist, you expect the potassium to either stay at baseline or increase a little bit, even though it's a diuretic. That's unique with these agents. So we have an aldosterone antagonist. What other drug classes could we use for resistant hypertension? This team here. Okay.
Loop diuretic.
Right. It is so important to keep those two straight in your mind as far as pharmacotherapy. Loops are like last line, like this, when we're at resistant hypertension. They're not what we add first line because they don't have outcomes data. I know I say that a lot, but they don't. And so it's important you start with a thiazide and not a loop.
Milleride.
Okay. What other things could we add? This team here.
That was the better one.
Would you do this at your room?
Oh, we added the renin inhibitor, aliskiren.
Yeah, good job. Yeah. So we haven't mentioned aliskiren until this point in time. Aliskiren is cousins with which other two classes? This team here.
Ace and R?
Yeah.
So you do this on ARBs.
Yeah. They just work further downstream in the RAS system, right? That's all the difference there. This team here, why don't we use aliskiren routinely then? I mean, ACEs, ARBs, those have pretty good indications. Why don't we use aliskiren routinely?
Room service. Is anyone here? It's like in the office, trying to check if anyone's there. Trying to make sure
It's a
you guys are
lot
all
more
here.
expensive than the other ones. But keep in mind that by the same principle that you wouldn't use an ACE and an ARB together, you wouldn't use an ACE and aliskiren together or an ARB and aliskiren together, because you're still predisposing that patient for increased risk of kidney dysfunction. Something to think about. What other down in the bottom of the barrel options do we have? This team here.
Automated blood pressure monitor.
A little bit.
Okay, so yeah. Our other agents, I am so glad that you have not mentioned them up until this point in time, because you should never use them routinely. Like seriously, we've maxed out everything else, and now we're getting to those agents that we add afterwards. What other agents did you learn about, like in pharmacology, that can treat blood pressure? Oh, good call. What is it?
Alpha 1 agonist.
Yes. Is that pre-synaptic or post-synaptic?
He meant alpha 2, didn't he? Because alpha 1 would cause vasoconstriction. Alpha 2!
Okay, what do you guys think over here?
That's wrong. It's not a receptor.
You guys just said it.
Dude, what drug?
she hit you with the Dipiro.
Which drug you talking about?
Right. I know you're the weird kid.
Oh, no, it's
but
a blocker. He
Dipiro.
said agonist. No, that's right. He's wrong, is what I'm saying. Because he said alpha 1 agonist.
And autoreceptor
You're the weird
handles the
kid. That's
negative.
Dipiro.
So what do we expect to occur with this team here? When we talk about physiology, if we agonize alpha 2, what's going to happen?
Why was he calling the autoreceptor alpha 1? That's annoying.
It stops the transmission.
And it's going to cause vasodilation, essentially. So you'll get vasodilation from that with our alpha 2 agonist. And what's that drug? Clonidine. Good job. Yes, so we could have clonidine. What's another vasodilator? While we're talking about vasodilators.
There's lots.
Hydralazine,
Hydralazine.
and minoxidil.
Oh, those are the weird extra ones.
Yeah, those are like
Starts with H.
Oh, those are ones
Hydralazine.
Hydralazine. No, but it's okay.
Hydralazine.
Oh yeah, there you go. Hydralazine. It's another vasodilator that we can use, again, very last line. These should not be used anywhere near first line. Okay, we should max out everything else and then move to these after that. So this is just what other agents can we potentially use when we've maxed out all of our first line data. And you will see people for first line start people on clonidine because it lowers their blood pressure. But it doesn't have what? Outcomes, right? It's the name of the game. So we can lower somebody's blood pressure with clonidine, but it doesn't have any outcomes to support it. So it's not a first or a second line agent. We're going to use these last line. So just to recap right fast, for resistant hypertension, these are patients that have 3 or more antihypertensives, one of which is a thiazide. We can use things like aldosterone antagonists, beta blockers if they're not already indicated, vasodilators, or allosterin. So again, these are going to be the ones down in the bottom of the barrel that we don't routinely reach for, but if you've tried everything else, this is what we go to after that. And we're going to talk more about clonidine and hydralazine tomorrow, so stay tuned. I know you're on the edge of your seats for that.
Yeah.
Okay,
So we do have to.
so our last patient today is going to be PA, 33-year-old female presenting in her second trimester. This is her first pregnancy. She's physically active, but she does have an emotionally unstable boyfriend.
The boyfriend's a problem.
It's Darth Vader.
Darth Vader.
Her boyfriend's Darth Vader. That's stupid.
So the first thing is, would you even recommend a medication for PA? And I'll put her case back up.
Recommend she leave Anakin now.
Actually, do they? I don't think we normally do.
IV.
Just right down here.
I want to say no.
Isn't there one you can use?
Yeah.
Labetalol.
But it said third
The first
trimester.
one.
I can't remember.
What trimester is she in?
What was the question? Would you
It's
recommend?
near the bottom of page 7.
Laurie,
Second trimester. Oh, she good.
But see, that's prior to the beta law. She's 152. So, yeah.
That's not your thing for this
Refer to OBGYN.
We will use the flip cards for this, but you do need to write down on your paper whether A or B.
I would say yes. You've got labetalol. Yeah, you've got labetalol, nifedipine, and methylodopa for outpatient therapy. So I would say yes. I would give this patient something to protect her arm.
She's eating right. She's eating healthy. She's physically active.
Yeah.
She can probably get rid of the
And
boyfriend.
it's pretty common during pregnancy for women to get high blood pressure. So
think the boyfriend should be pregnant now.
Yeah, he's stressing her out.
He's kind of a dick.
Kinda.
Kinda Darth Vader.
Kinda slaughters children.
Yeah.
He freaks out over bad dreams.
It is.
So we said yes, right?
So, is nifedipine, is that dihydroxyurea? It's methyldopa.
Methadopa was preferred for her, right? Or I see that they're both first line. The one
All
preferred over
three
the
of
other.
them. I don't think so. It doesn't say that. It says all three of those are first line for outpatient due to favorable safety.
What teams are still working? It's a IPR.
We know the answer.
Yeah,
We
the
have
alpha
no have to pick a
methadone.
medication. It's just yes or no. So yes.
Which part?
So yes,
Yeah.
it's no why, right? Okay, so
Yes, there are some because they're favorably, they're safe.
So you've got labetalus. You've got Helen.
increasingly used over methadopa because of fewer side effects considered a first-line agent. So labetalol is the first line, right here.
Labetalol.
Considered, yep,
So that
considered
must be
first-line agent.
That might be the next question.
So limited, it's not, it's table 1370.
So we're doing labetalol?
Not
Well, we don't have to prescribe anything yet. It's just a yes or no.
Yeah.
But eventually, yeah, we would do labetalol first.
Alright.
So, does it talk about efficacy between amphetamine and methadopa?
Methadopa long-term follow-up data support safety considered a preferred agent.
Both of them are probably
methadopa.
I think
It's not that.
if they're fixing to have a baby. But like
Down
outpatient,
here. What's the class?
outpatient therapy.
I have died.
What?
Nifedipine, what's the class?
You know what
The
drug?
dihydropyridine. I don't know if it's
Here, look, I can look. It's a slow calcium channel antagonist.
Okay, so.
No, these are pictures I took.
Okay, here it is.
Oh, it's like having your PowerPoint.
Well, if anybody could, and it's fine.
I wish I could hack into that.
It's like, what the heck?
Okay.
Sneaky, sneaky.
Okay, so let's go ahead and take a vote.
Is considered.
Get your flip cards ready. Don't pull them up just yet, but get them ready.
Yeah, I'm putting all these in a PowerPoint. I'm gonna put it in Google. So we can just like study it, like going through it,
Wherever we want to find.
kind of all the cases.
Okay? On the count of three, go ahead and raise your cards. So 1, 2, 3. Okay, so we have a couple no's and a couple of more yeses, but let's go ahead and see, why did you guys decide today for no medications?
Start writing your name on that.
Is that?
Oh, did you initial?
What was it? It says that ACE are in the brain are functioning here in pregnancy, and we're not sure if she's sick or not.
So we don't want to make a recommendation at this time. Okay. So she says that they don't want to make a recommendation at this time because they don't want to assume it's due to anything. They want to do more research into it, essentially, before they treat. Okay, what do you all think over here? You also picked no.
That's not a yes or
That's a really
Well, they said
big
no.
in between.
Kind of the same lines, but we just didn't know enough about her. We want to do a UA to look for protein in the hair, eclampsia, labs, medicine, hospital, chemistry, and allergy.
So they want to get labs first, is what you want to do. You mentioned an interesting word there. You mentioned preeclampsia. This team here, what do you think about preeclampsia in this patient?
I don't understand what that is.
What do you guys think over here? What's preeclampsia?
No way. I'm officially retarded.
Just because someone has hypertension during pregnancy, does that automatically mean they have preeclampsia? Okay, so what's the difference? Here you go.
It's associated with thrombocytopenia, impaired liver function, renal insufficiency, pulmonary edema, or cerebral or mental disturbances.
So, as of right now, we don't have a reason to believe that any of that is going on. But the key point here is that she would have systemic manifestations going on if she was going preeclamptic on us. Right now, she doesn't really present with those, but it would be something to look into. So we probably, either way, we're going to go ahead and treat today because we don't want her to progress to that point. That's the key thing here, is we want to go ahead and prevent that from occurring. But it can occur, and it's something that we want to address. So we want to go ahead and get something started in here. We did have a good point over here. What was it that you said about aces and arbs, Charlie? Yes. Good. I can't stress that enough, is that aces, arbs, and statins are given all of the time, and hardly ever are people thinking about contraception. So you need to always have that in the back of your mind as you're dispensing these, because they're dispensed a lot. Okay, keeping all of these things in mind, let's go to what we want to do for PA today. Not there, here. So what medications do you recommend for PA? Be specific with your name, dose, route, and frequency, and why you chose that particular agent. And then what do you want to monitor? I'll go ahead and put the case back up so you have it. This is also the last app for today, so if you have yet to contribute, now is the time. So go ahead and contribute if you haven't already. Make sure you write your initials beside your name and sign at the end of class.
So we're going to say labetalol because it's the safest and it's considered first line, right? What dosages are going to be the best options? I didn't print
You
out
wonder
that.
pregnancy dosage or something for adults?
Yes, sir. Don't quote me. 100 to 200 POBID. But I just Googled it, so it might not be accurate.
100 milligrams BID, is that what you said?
Max 1200
So
a day.
100 mgs twice a day? Is that what we're saying?
Anyone else want to back me up?
Yeah, sure. Why go higher?
Yeah, this says initial 100 milligrams or twice daily. That's monotherapy or added.
LOL, right?
Alex agrees with me.
So we got 100 mg BID is one.
No. We're not doing that. We got another third resource online for pregnant people. Nothing?
No, we don't have one online. We've got a book, but it's not with us. But we already know it's safe. We just need dosing. dosing stuff.
I was saying that the other day, we should leave weight out. Like
She can take it.
Was there not a
yeah,
pregnancy?
like leave out like something
It
that
has to be
looks
like a
expensive. Just
It says on Micromedics,
Like a
pregnancy
electronic.
adjust
Yeah,
dosage
like a really watched its face.
proportional
It's
to
like
the
$1
change
on
in
it.
lean body weight.
Yeah, I could see
Study
that.
dosage.
Yeah, I didn't know what that meant.
Yeah, then we'll do more than
I
one
saw
thing.
that too. I'm
You have to leave it in the
Does it
freezer.
give you a normal dosing?
Well, it'll definitely be gone. It's like 5 minutes there. They have too many things.
It says initial 100 milligrams twice a day for hypertension.
So do we want to do that? Start off with 100 mgs, and then as she gets bigger, I guess. So, anybody got anything else for me?
They're looking.
Should I put that?
You should put it 100 milligrams twice daily. With a max at 1.2 grams a day.
Alright, you can do the monitoring just so we can try to get everybody in here.
So it says it's, where did y'all find that it says it's safe?
It's in our
Here,
don't know.
it's pregnancy category C, but we know that C means that it's an old drug and they just haven't spent the money to do the research on it. But it says it's orally safe in Lexi drug. But it's right here.
It's on page 7, too. It just says favorable safety profiles. So we want to monitor efficacy, safety, and compliance for elevator. And I would say in 2 weeks, just because she's pregnant, you want to make sure nothing bad's going on and see if it does anything. Does that sound?
Yes, pizza.
Yeah, we had candy, cold pop. Yeah, we good.
What were they having at the hospital? Like, what was going on?
Yeah, we went to cafeteria.
Oh, y'all just went down to eat. I got you.
We had to eat.
I got you.
No, but that's gonna last you to dinner time. Oh, y'all ain't that much?
Don't forget to.
Yeah.
What was that? What? Pork?
It was little pizza.
Yeah, the whole pizza.
Horrible pizza.
It was a whole little pizza. No, it was good, greasy pizza.
That's the best kind.
You make the roast though?
I haven't had no time now, Lacey.
For what?
I studied and I'm still going to fail this test.
I asked her if she made the roast.
I'm going. This next set, I'm going. I'm going. And I'm going to do whatever I want to do because it ain't going to make a difference. I see that now.
It'll make a difference on this test because you know what to study for.
You know, not for who? Oh, I didn't think about. Oh, I thought she was going around. You know what I mean?
But I feel like the next two exams are going to be easier because we have established professors and professors we know.
Just give you just a couple more minutes to polish up those answers. Make sure that when you put your monitoring down, that you put down specifically what you want to monitor and how often you, like when you would like to follow up, so put a frequency with it.
2 weeks.
Did we put what we gonna monitor to?
Safety, efficacy, and
Oh, it's on
compliance.
this? Okay.
I don't know what that is. Just, you know.
My flag.
Pepper flag.
My flag, leave me alone.
Man-child. Man-child.
I'm a child man, actually. It's different.
Just a child.
I happen to like it.
If this was high school, if this was high school, you'd get made fun of constantly.
Good. I'd be like, I did it on purpose. You just wish you were this cool.
Bryce, are you the only one that didn't get to write a second time?
I didn't get the what? The second time?
Write a second time?
About what?
On the thing.
Oh yeah, I guess so. I can start next time.
Sounds
I guess
good.
tomorrow I can start.
It don't matter. I just want to make sure everybody gets points.
Okay, let's go ahead and finish this up. So this team here, what did you decide to do for PA today?
I'm gonna say I'm excited for Thanksgiving because I'm excited.
Oh, I'm too.
I'm excited for that.
For her treatment today, we would recommend the Philippine ER 30 milligram 1 by mouth daily, and we can titrate up depending on how she react to the treatment.
Okay, what do you want to monitor with your plan today?
We would want to monitor her blood pressure, heart rate, sign and symptom of edema, liver function, and ideally return to clinic in 4 weeks.
Okay. So we have a vote for nifedipine, ER 30 milligrams daily, ideally returning to clinic in 4 weeks. Who else picked nifedipine today? It's okay? Okay, in that case, what did y'all decide to pick today? Oh, that's what you chose. I see your hand now. It's all good. It's all good. What did you guys choose to start for PA today?
We chose the metal doper, 250 milligrams orally AID for the first 48 hours, and then we titrate from there.
And, wait a minute. So, for the first 48 hours and then titrate, so how are you going to titrate it after that?
Are we team Dr. Pepper?
Yes.
You're bored today?
This guy.
So it says we may adjust those at intervals for not less than every 2 days to adequate response.
That means they don't know either. No. But the reality is you can step up by the increment she's currently in right now. So you could go up to 250 and you could do 500 and 250 and then go up to 500 and 500 and kind of work your way up from there. I wouldn't do anything that complicated on an exam, but it's good to know as the pharmacist on the team. What does alpha, I gave that away, that's okay. What does labetalol block as far as receptors go? Okay, alpha, yes, but what does it also block?
Beta 2.
Beta, 1, 2, what?
It's
1.
both, it's non-selective.
What is
Yeah,
labetalol?
so it blocks everything. So labetalol and which other agent block everything? Carvedilol, right? That's important to remember. Okay, so we have a vote for methyl dopa, which is what you chose, which is not labetalol. It's okay. Because that's our other option. Okay, so we have a vote for methyl dopa, we have a vote for nifedipine. Did anybody start labetalol today?
Carvedilol hits
Okay,
alpha and beta.
so what specifically do you want to monitor with labetalol? What do you want to monitor with beta blockers?
Heart rate. There you go. Okay.
Heart rate. There you go. Right, and so heart rate would be something you would want to monitor with labetalol. Methyl dopa is a vasodilator. We would also want to monitor heart rate. Why? When we cause vasodilation, what happens to the heart? We get reflex what? Tachycardia with vasodilation, right? Because it's trying to compensate. So you can see reflex tach. So the 3 drugs that we use in pregnancy, just to recap before we go, are going to be labetalol, long-acting nifedipine. Tomorrow we're going to talk about detrimental immediate-acting nifedipine and methyl dopa. And you need to remember that ACEs and ARBs are teratogens, so those would completely be off the table in this case. But labetalol, long-acting nifedipine, and methyl dopa are all valid options in pregnancy to prevent preeclampsia and eclampsia from occurring. Okay.
There you go.
So that
You got
is
everything.
the end of the application for today. Tomorrow we will be here for hypertensive urgency and emergency. And I will see you then. Let me know if you have questions.
Alright.
Don't forget to sign your papers and put them in a stack on this table in the corner over here. Thank you.
I don't even understand. So excited.
I thought you don't work Wednesdays.
I do. I was supposed to work today, but someone's going in for me, so.
Oh.
I am going to work tomorrow, sadly.
Oh, so you're just switching days.
So sad. But I'm going to enjoy my sleep.
Better.
I'm going to try. Enjoy a good old cold beer.
Yep. What are you gonna drink?
Oh, just popping one open at home.
What kind of beer though?
Oh, a Blue Moon.
That's not real beer.
What's real beer?
I don't know. Imports. Blue Moon's literally just Bud Light. It's just they made it a little different.
Technically,
it tastes good though.
The price they charge me is not.
They market
domestic
it
beer.
as a
It's an imported beer.
They market it as if it's like a special brew. See, man.
boat drive out. While they drive an hour and a half, I come in 10 minutes like,